Assalamu alaikum. I'm Lotus Maarouf. I'm a current third year medical student, and I'm really glad and happy today to be giving you guys the shoulder and arm anatomy crash course. Now, I want to preface this by saying that this will be more of a dense session. There's a lot of details, and especially on the surface, MSK looks like a really easy block, but when you get into the nitty-gritty, and especially with the burnout of the end of the year, it can be a pretty difficult concept to grasp. Especially, I think you guys have more final before MSK, so it can be quite a cram. But inshallah, I will be focusing on the high yields. I'll be explaining today on my model right here to try to ease it up, which is me basically telling you guys من تحت لتحت إنه you guys should definitely be studying this block in the lab. This is not the kind of block that you can just study from the slides and totally get it. You really, really, really need to get to the lab, get hands-on experience. What I'd recommend is when you guys come back from the break, inshallah, and after you guys have done the crash courses, done the slides, whatever you've done, you need to take these slides and review on the actual lab models, and that's the only way where this information will stick. But inshallah khair, we're going to begin. We're going to be looking through around 5 lectures, and because there's a lot of overlap between them, you'll see sometimes things being repetitive or things that are simply not repeated again and again because I tried to kind of merge it and lessen the time it could take overall. Bismillah. طيب. Now, first of all, I want to start off with some basic house rules. Now, when in doubt, when you are lost, please always refer back to the anatomical position. What do I mean by anatomical position? I mean with the hand supinated and with the pinky towards your side or medial to you. This position right here is the one position that can help you a lot when you're solving questions, when you are trying to understand the movement of a muscle. Please always begin. This is your baseline. So when we say مثلا flexion, begin from flexion with this position. So see how flexion of the elbow starts from this position. Same thing goes for the shoulder joint because it can get confusing. But please, whenever you're confused about where something is lateral or medial, go back here. So when they say like the lateral epicondyle, how can I know what's the lateral epicondyle? I start off with the anatomical position. This is my medial side, this is lateral. So here's the lateral epicondyle. We're going to learn more about this later. Anyways, the second thing is that movement is always in the direction towards the muscle origin. Now you might be telling me, Lotus, I have no idea what the muscle origin or insertion is. It's kind of like I have no idea what's the difference between a tendon and a ligament. And here, I'm here to explain it. So first of all, origin is, we know, I'm going to give you guys an example of the bicep muscle. So each muscle, because it wants to move the bones together and because it wants to move the joints, it's going to be connecting basically one joint to another or one bone to another. It doesn't matter. But the whole idea is the first place it attaches, or the origin from its name, origin, where it starts off. This is an area where the muscle won't move at all. It's fixed and it's usually more proximal to you. So in this case, we have here, this is going to be the origin of the bicep muscle. Now the insertion is going to be more distal, so all the fibers are running then into the insertion where it's basically connecting from the origin into another bone for us to be able to move that joint or whatnot. Now, the thing about insertion is when the fibers are contracting of the muscle, they're shortening, right? But let's imagine here, this is my bicep muscle and the fibers are shortening. Now I want to know in which direction are these fibers shortening. Now, if I told you that the insertion, as a rule, always moves towards the origin, and I know that the origin is more proximal and the insertion is more distal, this means that when I'm shortening the fibers, the insertion will always move towards the origin, which means that this is how the muscle will move. This is very important because it will help you understand how a muscle can be situated and how it will allow for the movement. Do you have to memorize the origin and insertion in great detail for every muscle? No, but you should have a kind of rough idea of where the muscles are situated and what's origin and what's insertion. Okay? Like, now that we've done our basic rules, we'll do basic osteology. Now, one second. Yeah, basic osteology. Now, just a quick recap from concepts you guys took in F&D. So we have the appendicular and the axial skeleton. Axial skeleton is whatever bones you have in the midline. So what are the bones in the midline? Skull, spinal cord, and rib cage. That's your axial skeleton. Now, attached to the axial skeleton is the appendicular. for you to be able to remember it, appendicular is more like the limbs. So basically your arms and your legs attached either by the pectoral girdle or the pelvic girdle. And we'll know what the girdle is, the pectoral girdle is later on. Now, further on, since we know that the upper limb is going to be now an appendicular part of the skeleton, it's composed of different sections, right? So we're going to have, first of all, our arm. Then we're going to have first of all, the pectoral girdle, I'm sorry, which is basically the shoulder region. Then you're going to have the arm, forearm, and then hands. Now, the thing about the upper limb is that it's highly dynamic. It allows for fine tweaked movements, which these kinds of movements, you wouldn't even imagine them happening in the legs, because this is the beauty of the joints and the muscles of the upper limb. Anyways, now, first of all, we're going to begin with discussing some bones that make up the upper limb, and then we're going to go on to joints, then muscles, then the brachial plexus is going to be the big finale. Now, first of all, the clavicle. What's the clavicle? It's this nice bone that we all love to see. It's basically an S-shaped collarbone. Now, I want to preface this by saying that while we see it in pictures and on lab specimens, the plastic ones, not the real ones, as a very S-curved kind of bone, you really need to practice on the real bones because they'd be more straight than you think. And because usually when they're displaying in pictures the clavicle, they're displaying it either from a superior or an inferior view. But in reality, when you're looking at it anteriorly, like directly looking at it straight up, it's going to be more straight. But again, for the purposes of our learning, we're looking right now from the superior view. So again, we're going to have a convex and a concave. Convex means at the medial 2/3, which means that it's going to be curving outwards towards the person in front of you. So convex. And concave, it's forming a cave. So cave towards the lateral 1/3. So it's going to form basically an S, convex or protruding outwards medially, and then concave or caving inwards laterally. Now, the thing about the clavicle is medially, it's going to be a very thick kind of triangular shape. It's going to be very thick, like even the bone makeup is going to be a lot more thicker medially. And as you go towards the end, it will flatten. So it's going to start off as a really thick triangular shape. And as you go towards the end, it tapers out and it becomes kind of a thinner bone for it to be able to articulate with another thin structure, which is basically the acromion. It forms then the acromioclavicular joint. We'll discuss this more later. Now, it's going to be directly deep to the platysma muscle. The platysma muscle is just a muscle that overlies the neck. You don't have to know it. But yeah, it differs in the surfaces. Now, when I'm telling you superior versus inferior, it's a big difference in two things. First of all are the landmarks, the anatomical landmarks, and second of all is the surfaces. Superiorly, think of it as it's going to be very smooth. Why is it smooth? Is because it doesn't have much structures that are attaching to it. But inferiorly, there's a lot more ligaments and muscles attaching. So imagine, would you want a rough surface or a smooth surface for you to attach to things? Of course, the rough one. Now, inferiorly, this is very important. Again, I want you to orient yourself. So superior, inferior. Now, inferiorly, this is going to be, again, the medial portion, and it's going to be the thick, triangular, proximal or medial portion of the clavicle. Now we're going to have inferiorly. I'm looking at the clavicle from underneath. We have the costal tuberosity. Now here is going to be where it articulates with the first rib. So because we don't want the clavicle to just be freely moving while our rib cage is doing something else, we attach literally the medial portion directly into the first rib. Now the second thing is going to be the shaft. The shaft of any bone is just the long shaft, yeah. Pretty much self-explanatory. Then we're going to have the subclavian groove and the conoid tubercle. This, again, is very important because some important ligaments will attach. From the conoid tubercles, so think of it as a peak, and this peak now, as it's descending, it's going to cause or form the trapezoid line. And then we're going to have the acromial facet. Now, recall how I told you it tapers out towards the end. It becomes more of a thin bone. This is going to be the acromial facet, or basically the portion where it's going to attach to the acromion of the scapula. We're going to see it in a bit now. So I think, yeah, that's pretty much it for the clavicle. Now, a bit of a clinical correlation. Now, two things that we're going to be dealing with clinically a lot in MSK, they're going to be either dislocation or fracture. Now, for clavicle, when I'm asking you as a general rule, is the clavicle more prone for dislocation or fracture? Your answer should always be fracture. It's not dislocation. Why? We'll see how much reinforced the clavicle is. But the clavicle is really, really enforced with many ligaments, which means, as a general rule, and we'll discuss it more again, just to hit the nail on the head, when you strongly reinforce a bone, you keep it very stable in place. And because it's very stable in place, you have less mobility and less leeway for you to be able to take in rough movements. So rather than the joint displacing or moving out of place or popping out of its place, the bone will simply break. You're putting a lot of pressure on a joint, it won't dislocate, but this force will transmit to the bone, and the area where it's not as reinforced with ligaments will break. And this is what happens with the clavicle. Now, how do clavicle fractures usually happen? Foosh, falling on an outstretched hand. Now, as you can see, this gentleman right here, when you fall on your outstretched hand, you're directly placing all of that strong force onto the clavicle. The joint will most likely not displace, but it will break. Now, medially, you're going to have one joint, and laterally, you're going to have one joint, which tells you what's going to be out of the medial, middle, and lateral portion of the clavicle. What's going to be the most common place of fracture? It's going to be the middle. This is very important. Medially, it's going to be supported by a joint, the sternoclavicular joint. Laterally, it's going to be the acromioclavicular joint. So where is the place where it's less reinforced, less of a joint, less of a ligament? It's going to be the middle, so it's going to be breaking. Now, once I had this discontinuity of the clavicle, now the muscles are going to override their primary function. So the muscles, what you need to know is that they're constantly at a sort of tonic contraction. They're not actually like contracting, but because they're innervated by nerves, they constantly have this tonic tone, and you guys will learn about this in physiology. But because these muscles have this tonic tone, each muscle will override and do its own function. So for the medially, what do I have attached superiorly? It's going to be my sternoclavicular muscle. Right here, I'm going to have the scalenes, and right here, I'm going to have the sternoclavicular muscle. Now, the sternoclavicular muscle is going to pull the clavicle medially. So what will I see in these patients? An indentation, literally, from their skin, which is basically the portion of the clavicle that's broken. Now, laterally, now, because I lost this discontinuation with my chest, the arm muscles right here are going to do their own thing. Now, again, we'll learn about it more later, but the pectoralis major muscle is going to be responsible because it attaches at the humerus, the shaft of the humerus. What it will do is kind of pull the arm to the side or adduct and medially rotate, right? Medially rotate. So this is what the patient will present like. So if you see a patient coming in with an indentation in their neck and a adducted, medially rotated arm, suspect that this is a clavicular fracture. And I think that's it. Brachial plexus, and okay. This we'll learn more about once we understand where the brachial plexus is situated. Now, the scapula, moving on. The scapula now is a very pretty bone, but what I really want you to understand is its directions. What's a posterior and what's an anterior surface? Now, anterior surface means the surface that's directly touching your back. So right here, this is your back, and this is going to be the anterior surface. It's literally anterior. And the posterior surface is going to have one demarcation, which is going to be the spine right here. I don't know if it can be seen, this spine right here. So the spine is very important because it separates the bone itself into cavities or fossa. These fossa are going to be where muscles inhabit. So now this spine, if you follow it out, it's going to go again, just like the clavicle, it's going to go taper and have this kind of thing that goes up. This is what we call as the acromial process. It's very important because it forms our acromioclavicular joint. If you noticed, I said it in the beginning, this is your acromioclavicular joint. So the acromion communicates with the clavicle. Now, because we had these fossa, again, I mentioned that these are going to be areas where the muscles will inhabit. Now, if you look kind of medially towards here, or right here, you'll see something known as the scapular notch. Now, this is going to be a perfect place for a nerve and a artery to inhabit. And I think that's pretty much it for, yeah. Now, these fossa, how do we name them? Since I told you that this is the spine of the scapula, of the posterior surface, again, the spine of the scapula and its posterior surface. So I can divide it as supraspinous and infraspinous fossa. That's it. Now, moving on, we have the anterior surface. Now, if I were to unscrew this humerus, which مشوار, I'll see right here that there's going to be kind of a place right here, a cavity, and this is going to be known as the glenoid cavity. Now, why is the glenoid cavity important is because it's directly going to articulate with the head of the humerus right here, and they're going to form a joint, the glenohumeral joint, or basically the shoulder joint. And that's pretty much it for the glenoid cavity. Now, one very important structure, which, again, why all of these structures are being pointed out is because they're important attachment sites to either ligaments or muscles. Now, if you observe anteriorly, and this is going to be your clavicle, this is the glenohumeral joint. You notice this kind of bony structure that's protruding like a beak, like a crow's beak, right here, this one, like a crow's beak. So this is going to be, again, don't confuse it with the acromion. I used to do that. Follow the acromion with the spine. And then you're going to see this protruding thing anteriorly. This is going to be the coracoid process. Did I pronounce it as coracoid in the beginning? Anyways, the coracoid process. This is an important muscle attachment site. And that's pretty much it. Anyways, so moving on to the humerus. Now, this bone is going to be obviously the longest bone of the upper limb, and it's going to be proximally articulating with the glenoid cavity of the scapula. So right here, this is the glenoid, and this is going to be the head of the humerus, and they're going to be articulating together to form the glenohumeral joint. I think you guys are sick of me by now by mentioning these things. But now, more importantly, are going to be our tubercles or tuberosities, whatever you feel comfortable calling them. We have the greater and the lesser tuberosities. Now, very importantly is that the lesser tuberosity is going to be more anterior. So this is my arm right here, right? Let's imagine this right here is going to be my humerus. Now, anteriorly, right here is going to be the lesser tubercle. Posteriorly, it's going to be the greater tubercle. Now, why does it matter which one is greater and which one is lesser? Is because lesser, from its name, it's going to be smaller, which means that it's going to be an attachment site of only one muscle of the shoulder muscles. But for the greater tubercle, because it's a greater surface area, it's actually going to be three muscles, and we're going to be naming all of those later. Now, moving on, between those two tubercles, you're going to see a groove, and this is going to be known as the tubercular sulcus or groove. Now, this groove has two lips, and the medial lip and lateral lip. And again, how can I tell? Going back to my anatomical position. So this is going to be medial lip. This is going to be lateral lip. It's going to be farther away from me. Right? Right. Now we have two necks for the humerus. First of all is going to be the anatomical neck, and the second is going to be the surgical neck. Now, an easy way for you to understand why, or actually just a thing that you have to know why it's known as anatomical neck is because when we're looking at osteology and growth plates, this is actually a site of growth plates. So this right here is a neck, and then we have the surgical neck. Now, when I'm telling you which neck of the humerus is most commonly fractured, you should always say surgical neck. And it makes more sense because this is a head, it's kind of more difficult to break, but the surgical neck is a more common site to break. One more thing is that this sulcus is going to be an important passageway for the biceps tendon or bicipital tendon. We're going to see it later. Now, for the kind of distal portion of the humerus, I'm not as concerned with it because I believe Manal in her crash course, she covered it pretty well. But what I want you guys to know for the purposes of later on in the session is, first of all, the deltoid tuberosity. Now, the deltoid tuberosity is kind of this structure laterally, and it's going to be just a small bump. This is where the deltoid muscle will kind of attach to it, right? The second thing is going to be the radial groove. Now, the radial groove, this is my arm like this. I want you to turn it posteriorly, and you're going to see just a line like this going, and this is going to be the radial groove. And it's important because the radial nerve and the deep brachial artery will be running through it, which means when I'm fracturing a certain part of the bone, I'm worrying about certain structures because they pass in these anatomical landmarks. The second thing is going to be my epicondyles. Now, the epicondyle are going to be these two structures right here. You're going to have the trochlea, capitulum, whatever. Those are going to be covered later. So I'm just concerned with these, the condyles. Now, how can I tell what condyle is what? Again, anatomical position, supinate and your pinkies medial to you. So this means that this is going to be the medial epicondyle, and you should palpate it and feel for it. And this is going to be the lateral epicondyle. That's pretty much it. The rest are for your own knowledge and for you to review with upcoming lectures. Now, the humerus. Now, it also has it is prone for fractures. And again, when I tell you which neck is more common, you should always tell me it's the surgical neck, not the anatomical neck. Now, for the proximal humeral fractures, and again, we're going to learn it later on, but very important structures pass by, which are going to be the axillary nerve and posterior circumflex artery. They're going to be very proximally kind of wrapping around the surgical neck. So if I were to fracture the surgical neck, I will be in big trouble for these two structures. How can I fracture the surgical neck? Typically, it's going to be after a fall directly just to the bone, or a high energy trauma, which means that the patient was doing something very strong, or strong flexion, whatever it may be, that caused it to break. Now, the second type of fracture is very interesting. It's known as the avulsion fracture. Now, recall how I told you that the greater tuberosity, which is going to be more posterior, and more anterior is going to be the lesser tuberosity. The greater tuberosity has 3 muscle attachments, right? While the lesser is going to be only 1. This means that if I were to use these muscles that are attaching to the greater tuberosity in a weird way, I flex them really strongly or whatever, I could, instead of just having damage to these muscles, because these muscles pulled on the bone really quickly, they're simply gonna snap off like a piece of that bone. Now, what happens is, because I snapped off a piece of that bone, these muscles are gone. Khalas, they're gonna go contract, do their own thing. But what is going to be overriding now is going to be the muscle that's attaching to the lesser tuberosity, which is basically the subscapularis, and its function is medial rotation. So again, the patient presented with medial rotation and did some forceful abduction or flexion and resulted in injury, I'm going to be thinking of an avulsion fracture. Now, let's build the upper limb joints. Now, first of all, we're gonna just quickly recap some points about the classification of synovial joints. Before I get ahead of myself, I want to explain a synovial joint because, again, these are basics that we often forget from FND. Now, we have the bone, and the bone is covered by this thick collagenous connective tissue, collagenous fibrous connective tissue, which is known as the periosteum. Now, the periosteum is going to be covering the kind of the shafts of the bone right here. But at the proximal portion, or the portion where it's going to be articulating with another bone, basically forming a joint, it's going to be covered with a different type of cartilage, hyaline cartilage. Because think of it as bumper cars when you have that rubber kind of around the car. This is what the hyaline cartilage will be acting like. So I have this hyaline cartilage right here. Now, this is where the articulation of the two joints is happening. Is this enough for me to prevent the bones from breaking from the friction that they're causing to cause damage to these bones? No. The synovial joints are really smart. So what they do is actually have a surrounding capsule that contains a synovial membrane that produces or secretes fluid. Now, this synovial membrane, what's overlying it is going to be a joint capsule. This green right here is going to be the synovial, the joint capsule, which is essentially just fibrous tissue wrapping the joint from the outside and protecting the synovial membrane. And basically, we have now a capsule filled with fluid. So here's bone, articular cartilage, or basically hyaline. And here I have the synovial membrane, and overlying it or covering it completely is going to be the joint capsule, which is fibrous tissue. And this joint capsule, because it's also fibrous tissue, it kind of blends in with the periosteum. So it's a very nice, clean structure right here. Now, very importantly, that I want you guys to know is the classification of synovial joints, they're basically not all free mobile joints. I know that when you guys think of synovial joint, the first joint you guys think of is ball and socket, but that's not true. Ball and socket is not the only synovial joint. There's many synovial joints. And again, synovial joint is any joint that's just encapsulated and has a synovial membrane that's producing fluid to allow for lubrication of that joint. Now, the movement of a joint, this is a very, very important concept. Now, how do I classify non-axial, uniaxial, biaxial? How do I understand these axes? So whenever I'm describing a movement on an axis, know that the movement will be perpendicular to that axis. I'll explain this more when I'm giving examples, but for now, let's just quickly run through the synovial joint. So we have, first of all, the plane joint. Plane joint is uniaxial. What does this mean? It doesn't move. It allows for just small movements, gliding either anterior, posterior, to the sides, lateral, medial. But the whole idea is grossly, when you're looking at the person, the joint is not moving. An example of that is your carpal bones, your spinal cords. All of these things on the gross surface, they don't look like they're moving because in reality they aren't. They just have small, tiny tweaks of motion that allow for the kind of hand or whatever structure to move more freely and dynamically. The second type is going to be the uniaxial, which means it moves on one axis. Are going to be then we're going to have the hinge, and the pivot is going to be kind of similar as the hinge. So while the hinge is going to be kind of like a door hinge, the pivot is going to be kind of like you have one certain axis or rod, and then you're going to have rotation movement around it. So an example of that would be the dental and the atlas in the head right here. So this is going to be known as a pivot joint, and it's uniaxial. Then we're going to have biaxial, which is condyloid or ellipsoid. In shape, it looks like a ball and socket, which explains why it has a great range of motion. It's kind of like an egg with an egg socket rather than a ball and socket. And saddle joint, which is the one that you see in your thumb. Your thumb isn't the same as the hinge joints that you see in your interphalangeal joints. Yeah. Now, for the axes, which are a lot more important, why is this not moving? Yeah, right here is going to be the movements of the synovial joint. Now, again, I said biaxial, uniaxial, whatever. How can we distinguish this? How can we explain this? And again, I want to go back to, let me get this, a very important concept, which is that the movement will be perpendicular to the axis. So frontal, when we're describing frontal, what's frontal? Right. So when I describe frontal, what do I mean with frontal? So again, it's perpendicular to the axis. So this frontal, when we say frontal, this is what we mean, right? So right here, let's say that I'm looking at the shoulder joint and this is going to be the frontal axis. The movement, do you think a lot of us, when we were in first year, we think, okay, frontal axis, this means that the movement will be abduction and adduction, but it's not true. The movement will be perpendicular. So it's going to be forming a 90-degree with it. So frontal axis, it's going to move flexion and extension. Make sense? Same here. Flexion, extension. Same thing for sagittal. So sagittal, this is going to be frontal. Sagittal is going to be like this. So what does this mean? This means I'm going to be, again, 90 degrees. I'm going to be forming 90 degrees. Abduction, adduction. Inversion, eversion, and etc. And I think you guys got this by now. Circumduction is going to be a combination of everything. It's just circular motion like here, like this. Yeah, and it's going to be specific to ball and socket joints. No other joint can do circumduction. And yeah, that's pretty much it. Just one thing about pronation and supination. So this is pronation, this is supination. It's pretty easy. But for inversion and eversion, or internal rotation, external rotation, it can be a bit confusing in joints. So that's why don't look at how your arm is moving. Imagine how the ball and the socket is moving. So when I say medial rotation, again, imagine that I want the ball to be coming towards me. So this is going to be internal rotation. Here, I want the ball now to move away from me. So it's going to be eversion or external rotation, right? Or inversion, external rotation. Inversion, eversion, internal rotation, external rotation across the joints. Okay, moving on. Now we're going to build the upper limb joints, and this should be breezy and easy since we know the landmarks of the bones, we understand the movements of the joints, and we understand what the synovial joint is. So this is building all the basics now into the actual lectures. Now, first of all, we are going to have our sternum. This is going to be the sternum, and this is going to be the clavicle. So what joint is this? Sternoclavicular joint. Now, more about the sternoclavicular joint. This joint actually is a saddle joint, which means that, what does this mean? Which axis? How many axes does it move in? It moves in biaxial. It has two axis movements. But you might be asking me, Lotus, I cannot move my clavicles at all. And this is exactly what I mean when I say it's heavily reinforced. Now, in shape, it's a saddle joint. Does it act like a saddle joint though? No. Because look at this right here, we have ligaments. So the anterior and posterior sternoclavicular ligaments are going to be strongly kind of tying around a wrapper around it, allowing it not to move and show us its saddle joint activity. Of course, it has some freedom of movement, but it's not as saddle that you can see and appreciate maybe in like a thumb. Now, this fibrous capsule is going to be reinforced. Inside, I see an articular disc. And again, recall that I told you that the clavicle joint can face a lot of force, especially with Fuchs injuries, falling on an outstretched hand, which is why we have an articular disc. It's just a sort of thing in the capsule of the sternoclavicular ligament that allows for every time the sternum and the clavicle hit, it kind of acts as a shock absorber. That's the word I was looking for, a shock absorber. And again, the key concept that I told you guys about, a strongly reinforced joint is more likely to fracture under force. But in the same way, a joint that is very freely mobile is more prone for dislocation. So it's kind of things that we weigh out. If I want to strongly reinforce this joint, it's going to withstand the pressure, but it's going to transmit this force into the shaft of the bone or somewhere where it's less reinforced and cause for fracture. But if a bone has a great freedom of mobility, it's very prone to dislocation, and we're going to see how later. Moving on. Sternoclavicular joint, we said that the most common thing that you see, it won't dislocate. Usually the clavicle will just, especially at the middle portion, just fractures. But in case it did dislocate, again, in sort of a trauma directly to the chest, what we'll have is symptoms of difficulty breathing, because I want you guys to observe right here. What do we have directly behind? We have very important structures. We have the right subclavian vein, but very importantly here is the trachea, which means that if anything caused displacement of the sternoclavicular joint posteriorly, which is where it usually dislocates, and won't dislocate anteriorly. There's no mechanism of trauma that will cause it to do that. But usually it dislocates posteriorly and causes compression of these major vessels, the right subclavian, the brachiocephalic artery, and the trachea, causing for difficulty breathing. That's pretty much it. Now, moving on to the next joint, which is going to be here. I want you to observe the coracoid, which is going to be under the clavicle right here. So it's going to be under the clavicle. And here I'm going to have the acromial facet and the acromial process, again, all the way to the spine. Together, they're going to result in the acromioclavicular joint. Here I just marked the glenoid so that you guys know it, but it doesn't participate in this joint. It's just the acromion and clavicle. Now, this is going to be a synovial plane joint. Recall, what did I say about plane joints? They don't move. Like realistically, when you are looking at it from a very outside perspective, the joint doesn't move. But what's important about this is it acts almost as if, okay, this is a very good analogy for this joint. When you are kind of trying to catch a fish with the fishing rod, this is exactly what this joint does, is the connection between the rod and the string and the fish. So what this means is it allows it kind of acts as a sling to it. I don't know what's a good word, but basically it allows for this free motion, which is why the shoulder joint, it contributes to why the shoulder joint is very freely mobile. It kind of hangs it on the acromion. Hangs it on the acromion, yeah. Okay. This is pretty much all things we knew. Now, visiting the ligaments, importantly. Now, recall the conoid that I told you about, which is going to be on the inferior surface. And from the conoid, it kind of goes like this, or if we're looking at it, flipping it like this, it's going to be like this. And then this line right here is going to be our trapezoid line. This is the attachment site for the conoid ligament and the trapezoid ligament. Together, they form the coraco-clavicular ligament. Why? Is because they're going to attach to the coracoid process, which is, again, the anterior big thing. They're going to attach to it and reinforce the acromioclavicular joint, along with the acromioclavicular ligament. Very importantly, the coracoclavicular ligament, the whole idea is recall we had the costal ligament medially, and laterally we also want to kind of tether the clavicle towards the chest, or towards, yani inferiorly, not towards the chest, inferiorly. Now, what we could have clinically is, depending on how strong the injury is, if a person were to fall directly on right here, the acromioclavicular joint, our ligaments could be in trouble. And this is what we call a shoulder separation. Why? Is because the thing that will connect this axial skeleton, contributes to the connection of the axial skeleton and the clavicle to the limb, is going to be right here, this acromioclavicular joint. So what will happen is the arm will simply drop. Depending on how high energy this trauma is, I could only have dislocation of the acromioclavicular ligament without rupture of the coracoclavicular ligament, or I could, separation of the acromioclavicular ligament and joint without the coracoclavicular ligament being involved, or I could have both of them involved. This is going to be a very severe injury. Now, again, you always need to think of what the muscles will do. So since nothing is acting on the clavicle now, the sternocleidomastoid muscle will ride the clavicle up while the arm will drop down. Now, lastly is going to be our glenohumeral joint. This is going to be the glenoid cavity of the scapula. This is going to be the head of the humerus and glenohumeral joint. This joint is going to be a ball and socket synovial joint, which means it's incredibly freely mobile, even more mobile than the ball and socket that you see at the hip joint. Now, this joint is very mobile at the expense of its stability. A very good way that they like to describe it is small t and a big ball. Why? Because if you look at the surfaces, the glenoid cavity is kind of like this. It's only very shallow and barely curved, while the ball is a ball. It's very round. So imagine when they're articulating, and with the weak structures that surround them, it's very easy for it to simply dislocate. صح? Now, the body has an adaptation to this, and this is why we have kind of a fibrocartilaginous ring known as the glenoid labrum, which acts literally as if a plunger were to just plunge and suck the ball of the socket, ball of the humerus. So this is the mechanism by which we form our glenohumeral joint. Now, of course, it's not just that. We have the reinforcement of our ligaments. Now, these ligaments, I want you to look at them. So it's very easy. Glenohumeral ligament. We have the superior, middle, and inferior. And of course, all of these ligaments, and a very important concept that kind of confused me as a first year, are these glenohumeral ligaments are going to be part of the fibrous capsule. So recall how I told you and how I explained the synovial joint, how it's formed, what's the structure. It's basically going to have a fibrous capsule surrounding the synovial membrane. This fibrous capsule has certain parts of it where they're thickened, and this is essentially what your glenohumeral ligaments are. So this right here is going to be your fibrous capsule. This is going to be the glenoid. Then you're going to have surrounding it the labrum, and then you're going to have your glenohumeral ligaments, which are going to be thickened. And this joint is surrounded by what we call the rotator cuff muscles. Again, I want you to notice, and we're going to discuss the rotator cuff muscles in a bit, but notice where are they? They're more superior, and most of the contribution of the thickening of the fibrous capsule or the ligaments is going to be, again, more anterior, superior, less inferior. Very important. Now, another thing that I want you to notice how I told you it's a fibrous capsule that kind of engulfs this joint completely. Inferiorly, there's a loose or a lax portion of this fibrous capsule known as the redundant capsule, which means that, again, out of this, when I gave you all of this information, which part of the joint is most vulnerable for it to dislocate in case of a trauma? I hope you guys are answering by now that it's going to be inferior, because inferiorly we have less muscles, a more lax fibrous capsule, less ligaments, and yeah, that's pretty much it. Just to make sure I didn't miss anything. Okay. Yeah, just one more thing is right here. We have this again. I told you it's continuous. Right here, a small portion of it is going to be known as the transverse humeral ligament. Now we have here our sulcus right here, the sulcus, and this is where going to be the bicipital tendon is going to be passing by, or the bicipital groove. Kind of like a band-aid on top of it is going to be the transverse humeral ligament. Moving on. Shoulder dislocation. I gave you guys basically the gist of it, but basically the glenohumeral joint is the most frequently dislocated large joint. Recall how I told you it's the most mobile. It's even more mobile than the hip joint, and it's also the most frequently dislocated. Again, when you have high mobility, it's coming at the price of stability and dislocation risk. Now, the most common is going to be anterior and inferior. I want you guys to follow this radiographic image with me, and it's very important that you guys be very good with these, especially the ones provided in your lab. Chances are they're going to come as SAQ, and you need to interpret them. So the way you need to interpret is follow the structures you know. So this is clavicle. This is my scapula right here, and I know clavicle is articulating with the acromion. Now, this right here is going to be somewhere here, is going to be the coracoid process, and right here under the clavicle, and right here is going to be my glenoid cavity. Where's the head? The head is not articulating with the glenoid cavity, which means that I have dislocation. I can definitely tell that it's inferior. The head is going down, صح? Can I tell if it's anterior or posterior? No, you cannot. This is when you need a lateral view of the x-ray for you to be able to tell. And this is pretty much everything that I discussed. And one more thing, the labrum sometimes, the fibrocartilaginous ring sometimes is vulnerable for rupture, especially in older patients, which contributes to why it dislocates, this joint dislocates. Now, one very important concept I want to nail in the head is the shoulder girdle versus the glenohumeral or shoulder joint. Now, the shoulder girdle, what a mouthful, is basically comprised of two bones, the scapula and clavicle. This combination right here, the scapula and the clavicle. This combination is going to be my girdle. Why is it important? Is because it's going to form an incomplete ring. So again, because it's only two bones, it's going to form only an incomplete ring. Within the rest of the ring is going to be a contribution of my muscles and the rest of the structures of the back. Now, the only true articulation of the upper limb with the axial skeleton, very important and will probably come MCQ, is going to be my sternoclavicular joint. Because imagine this. This right here is part of the skeleton where I removed the sternoclavicular joint. Notice how the limb is completely gone. There's no limb attached. So this means that this joint is the only true attachment between the limb and the axial skeleton, or the appendicular skeleton and the axial skeleton. That's it. Now, moving on, this is just to nail it in the head. The glenohumeral joint is going to be the shoulder joint, which is going to be scapula and humerus. This one is going to be the only true connection, allows for the only true connection, which is going to be the sternoclavicular joint. It's going to be the pectoral girdle. What's the pectoral girdle made of? Two bones, clavicle and scapula. Be very good with this. Now, muscles, the basic movements of the shoulder joint, again, we kind of practice them together and know very well your axes. So when I tell you what are the movements of the shoulder joint at the frontal axis, again, frontal, so what will it be? Flexion and extension. Now, we are going to be moving on to the muscles that allow us to do all these lovely movements. And again, recall that the shoulder joint is a ball and socket, which means, honestly, I'd spend more time learning the movements of other joints rather than the ball and socket ones, because ball and socket can do all movements. Anyways, now, these tables look very overwhelming at first, but we'll run through them. And believe me, the origin and insertion, while annoying and tedious, you don't have to memorize them in great detail, but having an idea of them is very good. So first of all, to begin from this overwhelming table, we have the deltoid. Now this deltoid is going to be the muscle that acts as a shoulder cap right here. And again, origin and insertion are annoying, but let's look at them. So you're gonna have the lateral third of the clavicle, so right here, kind of towards the end of the clavicle and the spine. So basically it's going to be right here. This is going to be where it articulates this and the spine right here. So it's going to go right here, the fibers, and it's going to go and attach where, do you remember where on the humerus? The deltoid tuberosity. That's going to be the insertion point. Now this means that the insertion will move towards the lateral clavicle and the spine. What does this mean? This means that this is going to be the function that it does. Do you see how beautiful knowing the origin insertion is? Nerve, I want you to keep it in mind and memorize it for now. After we're done with the muscles, pause, take a break, and then start to the brachial plexus portion. Memorizing this will only make your job easier later on. Moving on to the supraspinatus, it's going to be, first of all, okay, wait, let me go through the pictures. Why am I doing it like this? So first of all, again, the deltoid. We said where the origin is and where the insertion is. Now, actually, the deltoid has multiple functions. Primarily, or the most important, is going to be the abduction of the shoulder joint, but it has different orientation of the fibers, which means different muscle actions. The anterior part, which is going to be more towards the lateral clavicle, what does this mean? This means that it's going to cause for flexion, slight flexion, and medial rotation, right? So slight flexion and medial rotation. Now for the middle fibers, which are going to be directly right here, so from contribution of both the lateral scapula and the spine of the, the clavicle, lateral clavicle and spine of the scapula, directly it's going to be doing the abduction movement. And specifically, I want you to keep in mind the degrees. Degrees are important to memorize. Then the posterior fibers are going to be the opposite of the anterior fibers. So again, it's going to be from the spine and to the humerus, which means when they're contracting, they're pulling the arm back and kind of laterally. So the anterior and posterior fibers have opposite functions, and the middle fibers are the most important, which is the abduction from 15 to 110. Innervations axillary. Now the clinical importance, again, recall what did I say about the axillary? It's very intimately related with the surgical neck of the humerus. If the surgical neck got in trouble, this means that I'll have trouble with my deltoid muscle. Does this mean that I completely cannot abduct my arm? No. And this is an important concept that you guys need to know when you're facing with nerve lesions. When a nerve is cut, this doesn't mean that the action is completely lost because the muscles have multiple contributions to the same function. So we'll find out that abduction is actually done by multiple muscles and not just the deltoid. And yeah, that's pretty much it. But the majority is going to be deltoid. So it's going to be severe weakening of the abduction. Now, moving on is going to be my supraspinatus. Look at it right here. So this is why I told you guys about the spine and why knowing the fossa is important. This is the spine. You guys can see the spine. This is going to be the spine. Supraspinatus is going to sit in this nice little pouch right here. Infraspinatus is right here. Now, the supraspinatus is going to be, again, I want to go back to where the insertion and origin is. But the insertion is, the origin is going to be the supraspinous fossa of the scapula. So again, the pouch that we're sitting right here, and it's going to go and insert where? Specifically at the superior facet of the greater tubercle. Notice how I told you the greater tubercle has 3 muscles. This is the first muscle. So what will it do? If I'm going like this and I'm going to at the greater tubercle, which is going to be more posterior. So right here, heck, like this. So this means that it's going to cause the initiation of abduction. It's only a small muscle. It's not going to abduct much, but the initiation or starting the abduction, very importantly, initiation is going to be the supraspinatus muscle. Deltoid is going to go and then take over. After the supraspinatus initiated, the deltoid will do the rest of the job. The next one is going to be infraspinatus. And again, it's going to be from the infraspinous fossa. So this is going to be supraspinous, infraspinous. Where will it go? Again, it's going to go from the origin and it's going to attach at where? The middle facet of the greater tubercle. Again, the greater tubercle. What does this mean? This means that it's going to rotate the arm laterally. Because again, if you are going to be kind of attaching the fibers from posteriorly and you're pulling it hic, it's going to cause for lateral rotation. Again, I really want you guys to nail in the head the origin and insertion because it very much helps understanding the action. Then you're going to have the subscapularis. It's a very small muscle from its name. No, sorry, I'm confusing it with a different muscle. The subscapularis. Recall how we said subscapular region? Oh, if we didn't say it, this is right here. So this is going to be the scapula. Under the scapula, because the scapula sits like this, right? So if I were to take it and see what's under the scapula, I'm going to see the subscapular fossa, which contains the subscapularis muscle. Now, the subscapularis muscle is going to go and attach where? At the lesser tubercle of the humerus. This is the only muscle that will sit at the lesser tubercle, which means if I'm going from my back like this, kind of snaking from my back and attaching to the lesser tubercle anteriorly, this means rotate the arm medially and adduct. So adduct and rotate medially. Now then we're going to have the teres major and minor. And what I want you to really nail in the head is the teres minor. Actually, let's go look at them right here. The teres minor and major can be seen both from the posterior surface. But if I were to flip the arm anteriorly, I'm only going to see the teres major. This is important later on. Okay. So again, the teres minor. First of all, let's start off since we're going at the posterior surface, supraspinatus, infraspinatus, and then I'm going to have here my teres minor. The teres minor, what will it do? Again, you're going to sit from the space that you're sitting in, then go to the greater tubercle, and what will it do? It's going to go and cause for lateral or external rotation of the arm. The innervation that you want to memorize. I think that's pretty much it. I didn't miss anything. And again, the scapular landmark is the spine to understand where the muscles are. Now for the subscapularis, which again we said it's going to be under the scapula, between the scapula and the back, the subscapularis, it's going to go and it's the only muscle that goes to the lateral, lesser tubercle, which is anterior, which means adduction and medial rotation. Very easy. Then we're going to have the teres major, and the teres major is very interesting in its shape. Let's go back to the origin and insertion. So again, looking at the teres major, we have here the scapula, and at the inferior tip right here, or inferior angle of the scapula, we're going to go and go kind of anteriorly onto the humerus and at the medial lip of the intertubercular groove. So again, recall how I told you that there's a medial lip. So it's going to go and again, kind of snake from the back on anteriorly onto the lip here. So what does this mean? This means that it will pull adduct and rotate the arm medially, just like the subscapularis, because they have very similar attachments. Now for the teres minor, it's at the upper portion of the lateral border of the scapula. What a mouthful. Here's the lateral border. And at the upper portion right there of the lateral border of the scapula, it's going to go on to the lower facet of the greater tubercle. So again, the greater tubercle. This is the third muscle. So first of all, we said it's going to be the supraspinatus, infraspinatus, and then teres minor, right? Yep, just making sure I didn't say anything wrong. So this is going to be all on the greater tubercle. What will it do? It's going to rotate the arm laterally. Again, just to kind of nail it in the head, right here. And then it's going to go and attach to the lower facet of the greater tubercle. So it's literally like this, just this. And then it's going to go and rotate the arm laterally. How will it do that? Kind of, again, snaking from the back and rotating the arm laterally. I hope this made sense, but this is pretty much it. Just know where the muscles are. I don't think you have to know the origin and insertion exactly, but knowing them would be nice. It will help you with memorizing the actions. And please memorize the nerves. We're going to get to them on the brachial plexus. Pretty much it. Okay. Moving on. Now we're going to look again. Remember how I told you that the shoulder joint has the rotator cuff muscles, and we basically took all of these muscles. It's just a matter of naming them. So again, hopefully you guys know this by now. This is glenoid. This is going to be the labrum surrounding it. This actually right here is going to be the bicipital tendon. It originates from the glenoid cavity. It surrounds it like this, and then it goes and runs, like it outpouches and then runs in the groove. It's very interesting. And then we're going to have the rotator cuff muscles. So first of all is going to be an easy mnemonic is, recall how I told you, three muscles on the greater tubercle. They're going to be the sits muscles. So sit, first of all, is going to be supraspinatus, infraspinatus, and then teres minor muscle. And then the only muscle that you have left is going to be on the lesser tubercle, which is going to be the subscapularis muscle. That's pretty much it. And this is going to be just a review of everything. And yeah, pretty much it. Now, subacromial bursitis. I didn't mention this, but this is going to be my joint. It's going to have the fibrous capsule. Now, right here, I want you to notice one muscle. What's this muscle? This muscle is going to go from, notice how it's coming posteriorly, and it's coming in from this nice little fossa right here. This is going to be the supraspinal area. Then it's going to go under the clavicle towards the tubercles of the humerus. And then it's going to be what? Our supraspinatus muscle. What does the supraspinatus muscle do? The initiation of abduction, right? Now, two things can happen in this area. Either I could rupture this tendon, it can get inflamed and it can rupture, which we can see right here on MRI. What does this mean? This means that I'll have painful arc. When I come in and I want to raise my arm, it will be extremely painful. Even though all the muscles, the other muscles are intact, the deltoid is intact, everything else is intact, I cannot abduct because of the immense pain. Another thing that could cause this inflammation is bursitis. Now, the bursa is just this right sac right here around or under the acromion, and from its name, subacromial bursitis. The bursa can get inflamed, and this could result or translate onto inflammation of the muscle. So, two conditions that I could have either the rupture of this muscle, which will result in painful arc, or bursitis. That's it. But specifically painful arc, sorry, not to confuse you guys, painful arc, specifically painful, is associated with inflammation. But the same symptoms or the same similar presentation could be if the supraspinatus tendon itself is not working. So it could either be that the patient is in immense pain because of this inflammation, and the area is going to be calcified because of the inflammation, calcific supraspinatus tendinitis because of inflammation, which results in painful arc. I can't initiate the arc, or the tendon is ruptured. Hopefully that made sense. Moving on. The muscles of the pectoral region are extremely easy. I'm not going to go into the origin and insertion in very great detail because it's very big muscles that are straightforward. So first of all, the pectoralis major. It's going to go from the anterior surface, and it's going to have the origin from the border of the sternum. And then it's going to go from the sternum and from the clavicle, from the sternum and clavicle. It attaches literally like this. And then it goes where? Specifically to the lateral lip of the intertrabecular groove. Lateral lip, again, recall, it's that one. So what does this mean? This means that it will adduct and medially rotate, right? Medially rotate. Medially rotate, perfect. Now for the pectoralis minor is, okay, this is going to be my pectoralis major. If I were to just remove it, cut it from here, cut it, free it from the clavicle, free it from the sternum, and remove it, I'm going to see a cute little muscle right there, and it's going to be pectoralis minor. Specifically where it's origin, this is important. You should know this origin, and it's going to be from start off from the ribs. Start off from the ribs. So the origin is from the ribs. Then it's going to go to the coracoid process of the scapula. What does this mean? This means that if the muscle is going to be moving basically like this, right? Like this. This means that it's because I'm taking kind of a sling. I'm taking from something that's anterior or posterior, a more posterior structure. I'm taking it and it's like a sling. I'm pulling it forward and downward. This is going to be the function, alongside with elevation of the ribs, of course, because it's attached, the origin is the ribs. I hope that made sense. Anyways, so that's going to be the function of the pectoralis minor. It's very important. So what will it do? Very importantly to the scapula, it's gonna kind of pull, because it is origin is going to be it inserts into the coracoid process. It will pull the coracoid anteriorly and downward, right? Because it pulls it anteriorly, and then it has the origin of the ribs. So this means that it keeps the scapula kind of taut against the back. Then we're going to have the subclavius, which is a very small muscle. It's just under the clavicle, and it's responsible for simply depressing the clavicle. It just depresses the clavicle a bit. And then you're going to have the serratus anterior. The serratus anterior is a favorite, commonly tested muscle. What it will do is the origin is going to go, and again, these muscles of the pectoral region start off. The part that doesn't move is on the ribs. And I keep confusing this even as I'm explaining it. It starts off at the upper 8 ribs, and then it's going to go to the medial border of the clavicle. So medial border of the clavicle right here. So it's going to go from the ribs all the way to the medial border of the clavicle, which means when it's contracting again, the insertion is moving towards the origin. This means that it's rotating the clavicle upwards, right? Because it will be moving basically like this. So when it contracts, it will moving the scapula kind of rotation upward and abducting the scapula, right? So moving it away from the midline. This is the function of the serratus anterior. Why? Is because it's going to go to the medial. It's going to start off from the ribs, and then it's going to insert at the medial border of the scapula, which means insertion moves towards origin, this right here. And very importantly, it's innervated by the long thoracic nerve. You should memorize all of the innervations, but this one is specifically important because it has clinical correlation, strong clinical correlation. And we move on to the strong clinical correlation. So when a patient, especially in patients that have undergone a radical mastectomy, which is basically removing the entire breast tissue, la qaddar Allah, on all females, due to breast cancer. Now, lateral to the breast, the long thoracic nerve kind of passes like this. It passes lateral to the breast all over the chest wall, which means that when I'm doing a surgery that's directly taking the breast, I have a very common complication of just cutting this nerve by accident. Now, the presentation of it is, again, what's innervated by the long thoracic nerve? It's going to be my serratus anterior muscle. The problem is when a patient will come in, she'll have her scapula is kind of protruding, right? And especially it will be most obvious in case she put her like this. So this is the wall right here, and she put her hands like this, you're going to see an outpouching hake. This is basically the scapula. It looks like a wing coming out. This is because you cut the long thoracic nerve as a complication of the radical mastectomy. Pretty much it. Hope it's simple enough. Moving on to the back region. Now the back, it's very easy, big muscles, but I don't want to confuse you guys. First of all, we're going to start most superficial, the trapezius and latissimus dorsi. Now the trapezius is going to start off from actually the occiput. So from right here, the back of your head, it's going to start off, and the superior nuchal line is basically the occiput. And then it's going to go all the way to C7 and T12, which is basically lower ribs, or lower spine, basically. It's going to go all the way right there. Like, this is my origin. The insertion is going to be the spine of the scapula, which means that when it contracts, it's going to be pulling in this direction. What does this mean? This means that it's adducting, it's rotating and elevating and depressing the scapula. So again, because it goes to the spine of the scapula, the acromion process, wait, right there. So because it goes right there, so I have the origin, and then I'm moving the insertion towards the origin. So it's kind of adducts, right? So one sec, adduct, adduct and rotate and elevate and depress the scapula. But أهم شيء is adduct. Now, why do we have all of these other functions? This, again, has to do with the fibers. I have upper, middle, and lower fibers. So upper fibers, again, remember that your origin is always the occiput and the spines, right? Or the spines, yeah, spines. So I'm moving the insertion towards there. If I'm looking at the upper portion, then this means that I'm simply elevating the scapula, right? So elevation of the scapula. So the shrug, shoulder shrug, very important. Middle fibers are going to simply retract the scapula, and then the lower fibers are going to depress the scapula. Again, why? Because the origin is going to be midline, and it's going to attach to the scapula. So it either can elevate, open up the chest, or depress, right? All of it at the level of the scapula. Very importantly is the innervation of the trapezius muscle by a cranial nerve, which means a nerve that's coming not from the peripheral nervous system, cranial nerves. So we know we have our cranial nerves and our peripheral nerves. Now the cranial nerve, specifically number 11, the spinal accessory, is going to be controlling the traps, which means clinically, when a doctor wants to test the integrity of the cranial nerves, they might put their hands on the shoulder of the patient and ask them, shrug, please shrug against my force, right? You guys will be doing a lot of that next year in neuro, inshallah. Then we're going to have, okay, so I started off with the trapezius muscle. I want to move on to the latissimus dorsi because it's going to be the most superficial on the back. It's going to go and have the origin from the thoracic and lumbar spinal processes. So again, from the midline is going to be our origin. It's going to go all the way to where? To insert in the floor of the bicipital groove. So basically right in the groove. That's where it's going to insert, which means it's going to, because again, imagine something is snaking from the back and it's going to be pulling towards the midline. So it's going to be adducting, extending, because again, imagine all of this sheet of muscle is just pulling the arm back. So it's going to be pulling it closer, pulling it back, and medially rotating the arm a bit. Now, these muscles are extremely powerful and they're going to be most superficial alongside the traps. So traps and latissimus dorsi. Now, if I were to remove or just kind of peel these muscles back, I could see more muscles, specifically my rhomboids, my rhomboid minor and major, and my levator scapula. Let's go to my levator scapula first. It's simply a very simple muscle and it's only responsible for elevating the scapula. You can see it from the upper border of the scapula all the way to, I'm not sure where it goes. Yes, to the transverse process of C1C again. So all of the muscles of the back, their origin is actually midline of the spine. So this just elevates the scapula. That's all you need to know about it, and it's innervation. But for the rhomboids, any movement, recall the movement that we said about the traps for the middle fibers. We're going to see the same movements for the rhomboids. Simply open up the back. That's it. And again, please remember the innervation. Now, this is just a review of the shoulder abduction, but since now we found out all the functions of these muscles, I want to put it all together and teach you how the abduction arc happens. First of all is the supraspinatus, the tiny muscle that's going to be from the supraspinatus fossa, that's going to go onto the humeral tuberosities. What will it do? It's going to be the initiation of the abduction. Then moving on, we're going to have our strong big muscle, the deltoid, which is going to pull the muscle to around above 90 degree by a bit, so 110. Now from 110 to 180, which is completely above the head like this, it's going to be the function of the trapezius and the serratus anterior. Why specifically is because trapezius is this big sheep-like muscle. You need something to pull very strongly to be able to reach above your head. And the serratus anterior, because again, remember, it works at the level of the scapula. Specifically, it rotates the scapula laterally, which is why it's a very strong, powerful abduction. Okay, now we've reached the axilla. Now, moving on to the axilla is just an area that is essentially everything that we spoke about, but we are putting kind of some boundaries to it. Now, the axilla is just your armpit, basically, and it's very much a pyramid-like shape. A very good way to observe this pyramid is right here in this diagram. right here. So as you can see, it's very much like a pyramid type of shape. So this is going to be the lateral wall, medial wall, meaning it's the wall beside you, lateral wall being your humerus, and then anterior and posterior. And even if you were right now to be palpating on yourself, you can very much feel the walls of the axilla. Now, specifically, where is the axilla? Rib one. So raise the arm, and then all the way from rib one, that is going to be where the axilla starts, at the base of rib one. And the clavicle, that's where it starts. Now, I was supposed to have, yep, right here. Now, the axilla is very important because a lot of important structures pass by it. I have here a ribbon to kind of represent the brachial plexus, the subclavian artery, and all the important structures that pass in the axilla. Now, the way they'll go is, especially for the brachial plexus, since it's coming from the spinal cord posteriorly, it's going to go under the clavicle and under the coracoid process and all the way like this to supply the arm. Isn't it beautiful? Anyways, so the base is formed by concave skins, cutaneous tissue, axillary fascia, and it extends to the thoracic wall or the medial wall. Now again, anteriorly, what is it? It's just right here. The muscles are beautiful pectoralis major and pectoralis minor, and the pectoral and pectoral and clavipectoral fascia. So basically, the fascia, to just describe it very simply, it's kind of the glistening tissue that you see on cadavers, and it's just a sort of sticky connective tissue that allows for the muscles and skin, for the skin and the muscles to adhere together. So that's essentially what's forming the main wall. Most important for you to know is the pectoralis major and minor. Ignore the rest, they're not that important. Fascias everywhere. Posteriorly, it's going to be the subscapularis and teres minor and latissimus dorsi, which makes sense. They're mostly all the muscles of the back, plus we're going to have the posterior muscle of the shoulder, the teres minor, and subscapularis because it's the muscle that's legit right here under the scapula. So again, anteriorly pectoralis, posteriorly it's going to be my teres, latissimus dorsi, and subscapularis muscle. And you might ask me, why the latissimus dorsi and not the traps? Because if you notice right here, you see this right here is going to be the latissimus dorsi. It's coming posteriorly and it forms almost a wing like this. But this will very much form a posterior wall. The trapezius is going to go up towards the occipital region. Now, for the medial, it's going to be formed by the upper fourth and fifth ribs. So again, because we recall medially, it's just the thoracic wall. It's going to be the upper fourth and fifth ribs and the intercostal spaces with, again, recall what muscle is overlying the, or kind of originating from the ribs. It's going to be the serratus anterior. And again, what does the serratus anterior do? It will kind of make sure that the scapula is retracted onto the back and it rotates it laterally so that we abduct the arm. Now, laterally, we have the bony wall, which is basically right here. So medially, laterally, again, anatomical position. What's more medial? My thoracic wall. What's more lateral? The arm. Of the intertubercular groove in the humerus. That's it. It's essentially the humerus and the bony wall of the intertubercular groove if you want detail. That's pretty much the axilla. Now, we said important structures form. This right here is just a simplified diagram. And again, just to very quickly review them, anteriorly, we have the pecs, pectoralis major, minor, doesn't matter. Right here is going to be medially, which is going to be our wall. What's on our wall? Ribs, fourth and fifth ribs. What's overlying the wall? Serratus anterior. There we go, medial wall. Now, I mean posteriorly, what's coming in? The wings from under. That's going to be my latissimus dorsi alongside my teres major. Am I missing a muscle? I feel like I am. Yeah, the posterior subscapularis. There we go. Teres major and latissimus dorsi. But this is very simplified. And then we're going to have the lateral wall, which is just the intertrabecular sulcus. That's it. That's basically the humerus is the lateral wall. Now you can see many structures right here. You can see muscles that we've yet to go through, but more importantly is the vessels, the artery, the vein, the brachial plexus and its branches, and the lymph nodes. And And lastly, just for the axillary sheath, you don't have to know this. It's way too advanced for your stage, but essentially it's going to be a kind of fibrous capsule that's surrounding all of these structures in the axillary cavity or fossa. Okay, now that we've discussed the borders of the axilla, I want to discuss one specific structure in the axilla. Now, of course, the axillary fossa contains the axillary artery, axillary vein, and some of the lymph nodes. And we have the axillary sheath, which you don't have to know the details about this, but it basically is kind of a capsule that surrounds all of these structures to make sure that they're tethered in place properly in the axillary fossa. But what I really want to focus on is the axillary artery. Now, as you guys know from anatomy by now, that when arteries transverse through areas of the body, they change their name as they're passing by through different structures. And the same thing is true for the axillary artery. In fact, the axillary artery is an artery you guys know, which is just the subclavian artery. But depending on where it's transversing, the name will change. So when we are in the neck, it's known as the subclavian artery. And then as it dips down under the clavicle, and recall what was the border, the superior border of the axilla, and I hope you guys are seeing by now that it's rib 1. So the superior border or lateral, specifically border of, right here. So the lateral border of rib 1, that's basically the beginning of my axillary fossa, which is the beginning of my axillary artery. Now, as I'm transversing and then I reach kind of the arm, first of all, we divide the axillary artery, depending in its relation to the pectoralis minor, into different names or different parts. So this is my pectoralis minor, this is the subclavian artery. Now I reached the lateral border right here of rib 1, so it became the axillary artery. We have the medial or first, and deep or second, or lateral or third parts of the axillary artery. All of these are in relation to the pectoralis minor. So medial to the pectoralis minor, or under it, or deep to it, or lateral to it. These are the parts of the axillary artery. And after I've transversed all of these areas, once I reach the arm and now I want to go and supply the arm, it's going to be known as the brachial artery. Now, the brachial artery will then go to the cubital fossa and divide into two branches, one which is going to be my radial and one which is the ulnar. And of course, we know that the one medial to us is going to be the ulnar, the one lateral to us is going to be the radial. Specifically at the cubital fossa is after we've passed by it, it's going to do the splitting. But moving on, let's discuss, and one more thing I missed, which is the axillary artery and its importance in relation to the brachial plexus. So this actually is part of the brachial plexus, and we name certain nerves in the brachial plexus. We're going to see it in a bit, but we name them into different names depending on if it's medial or lateral or midline to the second part of the axillary artery. If you recall, again, as we said, what's the second part of the axillary artery? I hope by now that you guys are saying that it's the, what was it called? The one deep to the pectoralis minor. But let's discuss the axillary artery in detail. So we said first, second, and third part, or medial to the pectoralis minor, deep to the pectoralis minor, lateral to the pectoralis minor. The first part will have one branch coming off of it. The second part will have two branches coming off of it, and I hope that you guys know by now the rule. خلاص, the third part will have three branches coming off of it. So the first part, let's follow here, subclavian, and this is going to be my first part. Why? It's because it's before the pectoralis minor. So this is the first part of the artery. I'll have a branch known as the superior thoracic artery, and it will supply the two areas of the first two intercostal spaces. So recall how the beginning of the axillary artery is at the lateral border of rib 1. So this means that the supply is going to be the upper two intercostal spaces. Moving on to the second part, which is going to be deep to the pectoralis minor, so this area right here, it's going to have two branches. First of all is the thoracoacromial artery, or trunk. Why trunk? Is because this artery, or this area of the artery, is going to give us multiple tiny branches to the pectoral, clavicular, acromial, and deltoid arteries. And these are going to go and just from their name, supply any area of this region. So the pectoral region, clavicle, acromial, and deltoid. And the second one is one that we're very familiar with. Why? Because we discussed how kind of the nerve will look like, which is lateral to the breast. Or did we discuss it? Anyways, lateral to the breast, we're going to have our long thoracic nerve. Running alongside it is the lateral thoracic artery. From its name, it's lateral to the thorax, and it's going to run at the lateral aspect of the breast specifically. And yeah, it's going to supply we said that the nerve, the long thoracic nerve, is going to pass this way and supply or innervate the serratus anterior muscle, which means that the lateral thoracic artery will be running with it and doing the exact same thing. Now, the last part, which is going to be lateral to the pectoralis minor, it's going to have three branches. We're going to have the subscapular artery. The subscapular artery. Now, the subscapular artery, one thing I kind of didn't mention is all of these arteries are mostly going posterior, specifically where posterior at the posterior side of the scapula, right here. This is where most of the arteries are going to be leaving and hiking up and anastomosing. We're going to see the anastomosis in a bit, but anastomosing at the dorsal surface, except the subscapular artery. It's going to be from its name an intimate relationship or on top of the subscapular muscle. Now, this artery is going to go off. It's going to give its branch. Now, afterwards, it's going to have like one tiny branch coming off of it, which is known as the circumflex scapular artery. This artery is going to go and anastomose and go. Actually, this artery is going to be anterior, we said, in comparison to all the other arteries and anastomoses of the axillary artery. But this branch is going to go, once it gives the branch of the circumflex scapular artery, it's going to anastomose and become more posterior. We're going to see where it transverses. It transverses through the muscle, specifically in the triangular space. We're going to see how it does that. But this is what I mean to say is, first of all, it starts off more anterior compared to everything else because it's at the subscapular region, but then it's going to go more posterior. And once it's done, it's anastomosis with the other arteries. Now, after we've given the circumflex scapular artery, it's going to continue as the thoracodorsal artery. Now, this is an artery we know by now, the cuff around the surgical neck. So we said it's going to be the axillary nerve. Alongside it is going to be the circumflex arteries. Specifically, we're going to have the anterior and posterior humeral circumflex arteries. Don't confuse it with the circumflex scapular artery, the branch of the subscapular. Okay, now this is an important concept, the arterial anastomosis. It can be a bit tricky and confusing, and I don't know how she could ask about this, but let's learn it. What you'd probably ask is the clamping concept and the the purpose of these anastomoses, basically. Let's explain it. So we said the subclavian artery in the neck, past lateral border of the first rib, then we're going to continue as the axillary artery. And depending on where we are, it's first, second, or third, or medial, deep, and lateral. Now, from the subclavian artery, actually, let's start from the axillary artery. Now, recall the last artery that we discussed, the subscapular one, the one that's more anterior, and that's kind of lying in intimate relationship with the subscapular muscle. It's going to go and dip down. And of course, we said that after it gave the circumflex scapular artery, that one branch that will go and anastomose, as you guys can see, the anastomosis here, it's going to continue as the thoracodorsal artery. Now, this thoracodorsal artery is going to transverse down and also anastomose with other arteries, such as the intercostal arteries, which are the arteries that run at the intercostal spaces and supply there. And then, yeah, it's going to basically start anastomosing. But the key here is the subscapular artery is going to just send a bunch of branches. So it's more inferior, right? Or lateral and anterior. It's going to start kind of, imagine this is the posterior surface. It's going to start sending branches up to go and communicate with who? To communicate with the thyrocervical trunk right here. Remember the thyrocervical trunk from the second part of the axillary artery. And it's going to anastomose. Now, this means that in case the axillary artery was blocked or was in trouble, I can still have a bypass or a way for the blood to pass by, avoiding the axillary artery. Specifically, where can I bypass? Where is the bypass still going to work? If I clamp anywhere between here, this area right here. So before the subscapular artery. Recall how I told you that of the story, the most important is the subscapular artery, because it's basically going to start sending branches up or more medial to go and anastomose and communicate with the thyrocervical trunk. If I were to clamp, after the subscapular artery, I'm going to be in big trouble. This anastomosis won't work. But if I were to clamp anywhere here before the subscapular artery, I'm good. I can clamp or stop the bleeding. And this is an easy flow chart for how the artery moves. Now, the axillary vein, I'm going to be explaining the vein as in branching, but in reality, remember that veins converge, they do not branch. because veins are taking peripheral circulation to the heart, to like the central heart. They don't, yeah, that's all I want to say. I'm going to explain it as they're branching because anatomically speaking, or for diagrammatic purposes, it's easier. But recall that the flow is going to be converging, not branching. طيب. So the same one, the subclavian vein now, it's going to go and it's going to go at the medial kind of side of the arm. Now, as it's going medially, it's going to continue. And again, we said that as vessels pass by, they change their names. So the same subclavian vein is going to turn and become into basilic. There's no axillary here, just basilic, okay? So it's going to become from subclavian in the neck into basilic in the arm. Now, notice here from the subclavian, I give off a tributary or an extra kind of vessel. This vessel is going to go now laterally because we supplied the medial, we're draining the medial side of the arm. Now I want to drain the lateral side. So how do I do that? With the cephalic vein. That's kind of a tributary from the subclavian. So again, this is your pectoralis minor, this is your subclavian. After the pectoralis minor, we're going to have our basilic vein. Now, the basilic vein is going to continue and it's going to be draining kind of the medial arm. The cephalic is going to be a tributary coming off of the subclavian and it's going to go laterally and drain the lateral side of the arm. So the actual flow of things would be the basilic and the cephalic, we're going to see that they're going to have a connection. The medial cubital vein, it's going to be connecting them in the cubital fossa. We're going to visit it in a bit. But again, all of the blood is going to be draining from the forearm. Then it's going to go to the basilic and cephalic veins, depending on if you're medial or lateral, respectively, and then into the subclavian above the pectoralis minor. Then to the jugular and whatnot. Easy. Now, for the axillary lymph nodes, it might look like it's really complex at first, but let's visit it. So this is going to be kind of my axillary fossa right here, and we said it's a kind of a pyramid-like shape. Now, I'm going to follow exactly the areas of this pyramid that we know and name these lymph nodes. So at the very superior border, which is lateral to the, what was it called? The first rib, it's going to be the apical node. Then at the center of this pyramid, I'm going to have the central node. Now the rest are extremely easy. The anterior are going to be, I'm hoping that you guys are saying by now, pectoral. The lateral is going to be the humerus, recall the humeral bone, the intertrabecular groove. Now it's going to be the humeral node. And medially, it's going to be the subscapular area or the subscapular node. That's pretty much it. Now, more importantly is for breast cancer, this area, يعني بعيد الشر عن all females and males, but the breast area is heavily, like 75% of the lymph coming to the axilla or axillary lymph nodes is coming from the breast. This means that any breast cancer that's happening, the first lymph node group to be affected is going to be the axillary lymph nodes, لا قدر الله. Specifically where? The lateral quadrants, because to explain it a bit, you guys don't have to know the details, but the breast tissue, we divide it based on the nipple. So the nipple is this is a breast, the nipple in the middle. Now we divide it into quadrants, 4 quadrants. Medial quadrants or lateral quadrants, or medial upper quadrant, medial lower quadrant, or upper lateral quadrant, lower lateral quadrant. This upper lateral quadrant is receiving most of the lymph from the breast, which means it's the first area you're going to see the breast cancer in most of the time. Now, moving on to the spaces, this is just applying all the muscles that we know, all of the vessels that we took, and I'm going to put them into spaces. Now, we're going to have 2 spaces and 1 interval. How can I remember which is which? These spaces are kind of diagonal together, so we're going to have the quadrangular space and the triangular space, and underneath them, so these are going to be diagonal, and one underneath them is going to be the triangular interval. So it's the only interval, so it's going to be under them. It's not going to be diagonal like they are to each other. طيب, the first is the quadrangular space. I want you to remember teres, minor and major. Of course, the minor is above the major. And recall how I told you that we can only see the teres major from the posterior side and not anteriorly. This is why it matters, is because we're going to see the quadrangular space posteriorly. So minor, major, bone, which is basically the humerus, the surgical neck of the humerus, and one muscle which we have yet to take, one skewing in between the teres is going to be the long head of the tricep. So tricep bone, teres, very easy. Now, what passes by them is the posterior humeral circumflex artery and the axillary nerve. We said this multiple times, but here, right here, a cuff over the surgical neck is going to be the axillary nerve. With it is the posterior humeral circumflex artery. This one right here. And this one, coming off the third part of the axillary artery, or the lateral part. Now, these are going to be the boundaries. This is, by the way, I didn't mention this, but it's incredibly auspiciable content. Yani, they might ask you, of course, MCQ, they can ask anything. But this specifically, this concept is very important to know over lab cadavers. The lab cadaver arms, they can ask you. So be very good with the boundaries, be careful and know how to identify which is which and which structures pass through. Moving on. The second, which is going to be the triangular space. So it's right parallel to the quadrangular. It's going to have very similar kind of borders. So the superior border is going to be the subscapularis or the teres minor. And this is where it matters. Recall how I told you here, we can only see the quadrangular space posteriorly because the inferior margin is the teres major and the superior is teres minor. Here, because we don't have the teres major, it can be either subscapularis or teres minor. So it can be from anterior or posterior view. Got it? Okay. Then the second one is going to be inferior, which is going to be teres major. And then the lateral, which is going to be the long head of the triceps brachii. One that's going to be, again, snaking through under the teres minor. Now, what arteries will be passing by is the scapular circumflex artery and the vein. Scapular circumflex, not the humeral circumflex. This is a picture that I wanted to show you guys. I probably should have put it earlier. But here, right here, we can see our circumflex scapular artery, and you can see how it's sending a bunch of anastomosis all around the dorsal parts of the scapula. But more importantly, do you see this communication right here with the thyrocervical trunk? Very important. Yeah, that's pretty much it. Now, and the vein. So that's pretty much it. Then the triangular interval, which is going to be underneath them. Now this one is also easy because it's kind of like a V. So it's going to be tricep, like this. So the medial head and the long head, or the medial long head, or one second. Which is going to be, we're going to have it's kind of like a triangle. So we're going to have, because it's triangular interval, we're going to have the medially the long head of the biceps and laterally the lateral head of the triceps. Triceps, did I say biceps? Triceps. Anyways, triceps. And you could say that the teres major is the superior border, but it's an interval. We don't care about it being a space. It's just an interval. But it's going to pass by our radial nerve and deep profunda brachial artery. One thing about both of these structures, those two structures, is they're basically a direct gateway to the posterior arm. Recall how I told you that, which one was it? The triangular space is basically the space by which the anastomosis is going to go from the one subscapular artery from the third part of the axillary. It's going to go and be more anterior. Then it's going to go actually through this space, the triangular space. Is it? Yeah, the triangular space. And it's going to go and hike up posteriorly at the dorsal surface of the scapula to anastomose with the thyrocervical trunk of the upper parts of the axillary artery. Here, the triangular interval will pass by structures that will communicate to the posterior arm, the radial nerve, and the deep profunda brachial artery. We're going to look at this in a bit. Now, for basic anatomy of the nervous system. Now, I want to begin this by saying this is not in your lecture, but I did include it because it's basics of the nervous system that will help you immensely understanding some of the more clinical concepts of the, what was it called? The brachial plexus. And another thing I want to say is I will be mostly explaining how the brachial plexus moves and its structure in the body. But for the actual nerves, memorizing each function of these nerves is going to be your job. I've listed them all on the side, but please make sure that you're good with memorizing the muscle functions, all of them, either of the shoulder region or the arm, so that when you come to the brachial plexus and you see, oh, this nerve innervates blah muscle, you know what action it's responsible to do. Another thing is for the sensory innervation, draw on your arm. That's the easiest way I can. If you don't like it, draw on a paper. You should have a map in your mind of what innervates what, sensory-wise. Anyways, the central nervous system is going to be your brain and spinal cord, yada yada, we know. And off of the brain, we have 12 pairs of cranial nerves. And I hope by now that you guys can tell me what cranial nerve innervates what out of these muscles. It's actually going to be the trapezius cranial nerve number 11. And then the spinal nerves, which are coming off of the spinal cord to just supply the body. Now, this right here is what I care about. We have the anterior side of the spinal cord and posterior side. Right here, we're going to have our gray matter, and anteriorly, it's going to be motor neurons. Posteriorly, it's going to be sensory neurons, sensory pseudo-unipolar. Now, roots are going to come off both of these sides, and then specifically the sensory part is going to have and pass by through the dorsal root ganglion. And after all of them will give out their roots, they're going to converge and become the spinal nerve. Now, what's important about the spinal nerve is that it's mixed, which means that it will contain both motor and sensory innervation. Very, very important concept. Now, after I've had this, I'm going to go and divide further because the spinal nerve can't reach both anterior and posterior sides of the body easily. It will form rami, or basically rami means bridge, ventral and dorsal rami. Again, the rami are going to be both motor and sensory because we mix them at the spinal nerve. Hello? Ventral rami are going to go anteriorly to the body, and then they're going to form the plexuses, which is why the plexus will have both motor or sensory, or both. Some of the nerves that it's giving off can be either sensory, motor, or both. And this is why. This is like the explanation to why it's that. Now, we said that it's coming from the ventral rami of the spinal nerves, C5 to T1. By the way, the roots that I was describing here aren't the same as the roots in the brachial plexus, just to tell you. And they're situated partly in the neck and the axilla. Now, recall how I told you the way it passes by. This is going to be my axillary sheath. Let's say it's going to be the sheath that contains the vein, the artery, and whatnot. It's going to go under the clavicle and under the coracoid process and to the arm, like this. Now, it's going to go and we have the anterior scalene muscles and the posterior scalene. These are going to be the muscles of the neck. Recall this one is the sternocleidomastoid, and here we have the scalene muscles. Coming off of them is going to be these 5 roots, C5, C6, C7, C8, and T1, okay? Now, how can I block these? How can I block the brachial plexus? Do I have to make the patient sleep totally? No. What we can do is, rather than general anesthesia, which is making the patient sleep, we can do something known as, what was it called? Local anesthetic. Anesthesia is just a drug that you can inject or infuse around the nerve. You don't inject it in the nerve, that will paralyze it, but you infuse it around the area of the nerve, as you can see here. And what it will do is inhibit the sodium channels, which means I don't propagate the action potential and I can't feel or move the muscle. Now, the brachial plexus. I want to get to this mnemonic. Remember to drink cold beer. Astaghfirullah. Or you can say Robert Taylor drinks cold beer. The whole idea is to remember the flow because what do you call it? The flow? الترتيب. The order, yeah. The order matters. So root, trunk, division, cords, and then branches. Now, I don't believe in just memorizing from pictures. I really think that anatomy should be drawn, which is why we're going to draw the brachial plexus together. I hope you guys have a pencil and pen following with this. So first of all, put to your side, remember to drink cold beer, RTDCB. So you know, root, trunk, division, cord, and then branches. And for the branches, we have important terminal branches. I want you to write the mnemonic MARMO. MARMO, so musculocutaneous, axillary, radial, median, and ulnar. And we'll see where they come from. Why. So the first is going to be my roots, C5, C6, C7, C8, and T1. Now, coming off of these roots can be some nerves, but for now, I want to just flow through the big diagram, and then we're going to see the small tributary nerves that come off from either roots or trunks or whatnot. Then, after I join the roots of C5 and C6, one sec. Now we have C5, C6 are going to join together to form a trunk. And then C7 is going to continue as a normal trunk. And C8 and T1 is going to also form a trunk. They're going to join together the roots to form a trunk. So upper, middle, and lower, or superior, middle, and inferior. Those are going to be your trunks. Now the trunks are going to divide into anterior and posterior divisions. Anterior, posterior, and anterior. And the thing about divisions is we don't have any branches coming off of them. So you'll see a branch off the roots, you'll see a branch off of the trunk, but you won't see any branches from any of the divisions, okay? Then we're gonna have the cord. How do I form the cords? I'll basically join all of these. Now this posterior and anterior is just done so that the diagram doesn't look too messy. But anyways, you'll join all posterior divisions and form the posterior cord. Pretty easy, صح? Then we're gonna have the anterior divisions from the upper and middle trunks. They're gonna join together to form the lateral cord. And then the anterior from the lower trunk is gonna just continue as the medial cord. Okay? Now, keep in mind that when we're talking about, okay, you told me you wanted to teach me where are they anatomically. So when you're going to go to the lab, anything that you see mostly in the axilla is a cord, and anything that you're going to see in the neck are going to be the trunks and the roots, okay? Right. Now, the lateral cord is going to give a branch, and the medial cord is going to give a branch. Those two branches will join and become one nerve right here. This is going to be my where was it? Where did it go? This is going to be my median nerve. Now, the thing about why is it called median is because when you look at the arm, and I told you that the cords are going to be in the axilla. So now, as you're seeing here, the upper arm, you're going to see a direct M exactly midline of the artery. So let's go back to that one image where I told you the M will matter. Right here. So do you see this M right here? It's exactly midline to the second part of the axillary artery, which tells me that this is my median nerve. And then you're going to have medial and lateral. You're going to see the medial and lateral cords. And again, everything, I want you to appreciate how it's going to be in relation with the axillary artery. طيب. Where are we? Medial cord. Okay. Now, appreciate this M, and you can appreciate it on a cadaver. So whenever you're lost about where to find something in the brachial plexus, go back to this M and then retrace your way backwards or forwards, however you want. Again, the lateral cord will just simply continue on its way and become the musculocutaneous nerve, which is a branch. So again, we did the cords, and now we're seeing the branches. So the median nerve is a branch of both the lateral and medial cord. Medial cord, sorry. Median means directly midline. Medial means medial. Anyways, the lateral cord will continue and become the musculocutaneous nerve, and then the medial cord is going to continue and become the ulnar nerve, okay? طيب. Going back, now I didn't go through this at first because I wanted you guys to appreciate this M right here, and because these are part of the marmu, the very major branches, I want to go now to the rest of the marmu, which is from the posterior cord. Now, the posterior cord will actually continue posteriorly and give us two nerves, the axillary and radial, which we've discussed before. We discussed how the radial is in very intimate relationship posteriorly with the profunda brachii artery, and the axillary is going to wrap around the surgical neck of the humerus. But they both come from the posterior cord. This is the M that I want you to appreciate from both the lateral and medial cord, giving branches to share and create the median nerve, which means that when they tell you what are the nerve roots of the median nerve, you should be able to list all of these. صح? صح. طيب. Now, where is it? Yep, we're gonna go to the tributary branches that are coming off of this nice pretty thing. So first of all, remember how I told you that some of the roots, not all of them, some of them will have a direct branch. Let's go to C5. C5 will give us the dorsoscapular nerve. This C5, so directly, what is it? Just coming off of C5. We won't involve any of the other roots. It is a nerve that will supply the rhomboids and my levator scapula, so the muscle that opens up the chest, and the levator scapula, which elevates the scapula from the same. Then we're going to go on to the long thoracic nerve, and we also discussed it. It's going to be lateral to the breast, coming off of, walking alongside the lateral branch of the axillary artery. And this long thoracic nerve, observe how from C5, C6, and C7 are all going to converge into one nerve, صح? And it's going to go and supply the serratus anterior. And again, recall clinically, if I were to cut this nerve by mistake in a radical mastectomy, or when I'm removing the breast tissue, when the patient, I ask her to put her hands on the wall like this, I'm going to see an outpouching or a wing-like structure, and that's my scapula, because nothing is tethering it to the wall anymore. And these are the only two nerves out of this plexus that will come out of the root, okay? Moving on. We said dorsoscapular and long thoracic from the roots. Can I have branches from the trunks? Yes, I can. I have from the upper trunk the subclavius nerve and suprascapular nerve. They're very self-explanatory from their name. Subclavius, it's gonna just innervate the one that depresses the clavicles, the subclavius muscle. And supraspinatus and infraspinatus are going to be innervated by the suprascapular nerve. They're very close to each other, so you can say, the nerve is innervating both two in one. And both of them are coming from the upper or superior trunk. Now, did you notice any other trunks that I said? No. So from C5, C6, and C7 are going to be the roots that give off branches. And from the upper trunk, I'm going to have the suprascapular nerve and subclavius. طيب. Where am I going? Okay, the lateral cord branches. Now, the lateral cord itself, we said from the divisions, notice no branches. So I can have a branch from the roots, I can have a branch from the trunks, but I can't have a branch from the divisions. So I'll just go and skip it and go to the cords. Now, the cords, I will have branches. First of all, I have a terminal branch. What do I mean with terminal branch? I mean that the cord, eventually, the original cord is going to keep on coursing as a nerve. And this nerve, as it's coursing, is going to be the terminal branch, which means nothing after I receive this branch, nothing more will branch off the nerve. I hope this made sense. So the lateral cord is now coursing, and it's going to give me a branch known as the lateral pectoral nerve. This lateral pectoral nerve, from its name, will innervate the pectoralis major and minor, but mostly it will innervate the major because the minor pectoral, the lateral pectoral nerve will actually send fibers to the medial cord, and from the medial cord we have the medial pectoral nerve, and they're going to go, both the branches or the fibers from the lateral pectoral nerve and the medial pectoral nerve will go and innervate pectoralis minor. I hope that wasn't too confusing. But anyways, notice how I gave the lateral pectoral nerve. After I gave it off, the lateral cord will continue as the musculocutaneous nerve, which is a terminal branch. For the musculocutaneous nerve, it's musculocutaneous from its name. What will it do? What are its functions? Again, terminal branch. It will have muscular component to all the flexors in the arm. Make it easy on yourself, and we're going to see the flexors of the arm in a bit. And the cutaneous or sensory component, where it's going to go and supply the lateral side of the arm. So it's going to go musculocutaneous, go like this, and then supply the lateral side of the arm. Okay? Lateral skin of the forearm, not arm. Where am I? Now the medial cord branches. So we said the lateral cord, and we said we had two branches, the musculocutaneous and lateral. What about the medial cord? Now the medial cord is busy. It has 3 branches before it becomes the terminal branch and gives me my ulnar. And of course, don't forget that the medial cord will give a branch to contribute to the formation of the median, directly midline branch. Okay? Now, I'm going to have, first of all, the medial pectoral nerve, because we discussed it. It's going to go and communicate with the fibers of the lateral pectoral to supply my pectoralis minor, okay? Yeah, right here. And then I'm going to have my medial cutaneous nerve of the arm and medial cutaneous nerve of the forearm. From its name, it's telling you that it will supply the medial side of the arm. So medially, from the arm, everything is supplied by the medial cord. Laterally, the lateral cord will deal with that. But medially, right now, it's going to be the medial skin of the arm and medial skin of the forearm, specifically C81, C81. Again, we always trace the cord to the roots here, C8 and T1, because that's initially how it joined and formed. And the ulnar nerve as a terminal branch. Now, the ulnar nerve, what I really want to bring it to you guys is back to the condyles. Recall how I told you at the distal humerus, what do I care about? I care about the condyles. So these right here. Now, I want you to palpate them, specifically your medial condyle, and I want you to very well palpate it. There's a groove right here. Now, this groove is the perfect place for the ulnar nerve to kind of hook and pass and go and supply the arm. Specifically, where will it go? It's going to go and have articular branches, muscular, all of that. You guys have to know the details of this and memorize it, but I promise you it will be a lot easier to memorize after you've went through the forearm muscles and whatnot. And for the skin innervation, you have to know that too. Now, another nerve. Now we discussed the branches of the lateral cord and medial cord. I want to revisit the median nerve. Why? Because it's contribution of both lateral cord and medial cord joining and forming the nice foot of the M. Again, it's the principal nerve of the anterior compartment of the forearm. What does this mean now? Recall how it's exactly midline. Muscles of the arm are going to be, or flexors specifically of the arm, are going to be what? Musculocutaneous. What about the muscles or the flexors of the forearm? These are going to be, what about the flexors of the forearm? It's going to be the median nerve. And again, it has no branches in the arm. It's going to just transverse its course and then go and supply the forearm where it wants. طيب. Yep, the same. And again, remember this, draw it as a map on your hand. You'll make your life easier. طيب. One second. Now, we dealt with the medial cord, the lateral cord, and its contribution, which formed the median nerve. And we dealt with the terminal branches, musculocutaneous, median, and ulnar. Ulnar supplying the forearm, median supplying the forearm to musculocutaneous, mostly supplying the arm. Now, what about the posterior cord? Now, the posterior cord will be all of the posterior, so of course it's going to be posterior, but it's going to form from all the posterior trunks. So everything, all the posterior divisions, sorry. So everything about it is posterior. Posterior divisions, posterior cord, it's going to go and supply the posterior compartments of the arm. And all of the roots are contributing, because recall, I told you, if you want to know the roots that are contributing to a nerve, always trace it back to where they began. So I took from every posterior division of every trunk, which means from C5 to T1, I have a contribution to this cord, okay? طيب. The first branch, they're very easy actually. Suprascapular, thoracodorsal or middle suprascapular, and lower suprascapular, very easy. Upper, middle, and lower subscapular, not supra, subscapular. And these are the nerves that, I mean the muscles that it innervates. But more importantly, recall how I told you that the posterior cord will then just move forward and split into two, the axillary nerve and the radial nerve. These are the terminal branches of the part of the marmo, the mnemonic. Let's visit them right here. Now, the radial nerve is very important, and it's the largest branch of the brachial plexus. Why? Because recall, I told you posteriorly in the arm, I have one nerve that's doing all the work for me, and it's mostly the radial nerve. But keep that in mind, and it's very easy. It's the largest branch, so it will supply most of the posterior arm. It's dealing with a lot. And yeah, these are going to be its branches. Please know them, and please remember what muscles are innervated. See, this is why triceps brachii, we've still yet to take it. So I want you guys to revisit those after you've reviewed everything and memorize them very well. But for now, just basic map. طيب, and then we have what's left, the axillary. The axillary is actually very simple, the cutaneous innervation, because it wraps around the humerus. So this right here is going to be the axillary sensory innervation. And the teres minor and the deltoid. So again, anything that's in that area, the deltoid. This is the sensory innervation and the teres minor. Perfect. And that, we're done with the brachial plexus mostly. Now I want to apply some clinical applications, and please, 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 everything we've discussed, memorize well, understand it, because most of the questions that will come from the brachial plexus are not going to be direct questions. It's going to be actually, what was it called? Clinical applications. So a person is going to come with a certain deformity, like maybe claw hand, and they're going to ask you what part of the brachial plexus is affected. طيب. Now, I discussed intimately how it's related with the humerus. This should be reviewed by now. Axillary nerve and the humeral circumflex artery are going to be at the neck as a cuff. Then if I move to the posterior arm at the groove, at the radial groove, I'm going to find the radial nerve and the profunda brachii artery, midshaft. Now, supracondylar region, just to put it into perspective, this is going to be the neck, the surgical neck. This right here is going to be the midshaft. This right here is going to be the supracondylar region. These are the condyles. This is supracondylar or above the condyles. And then I have the medial condyle, which is important for the hooking of my ulnar nerve. Supracondylar region, actually, I'll have what's going to be in trouble. It's very easy. What's midline is going to be my median nerve and the brachial artery. طيب. Now, this is a bit of a clinical application. How can I test the integrity of the spinal segments using the brachial plexus? How can I do that? First of all, the concept of the proximal distal gradient. Know that closely or more proximal to you, the superior or upper roots are going to be mostly responsible. So when I'm moving the shoulder, most of the nerves that are moving the shoulder are going to be contribution of C5 and C6. But distally, when I'm looking at my fingers and my hands, it's going to be C8 and T1. We know that all of these will innervate the arm, but the ones that are upper are going to be more proximal to me, and the ones like C8 and T1 that are lower are going to be responsible for the innervation of the distal arm. طيب. This is important because now, depending on the movement, I can, or the sensation, so I know here is the axillary or whatever, redo, depending on the, what was it called? Depending on the function or what area am I looking at in the arm, I can assess the integrity of what level of the spinal cord is intact. So for example, shoulder abduction, or shoulder abduction is moving it away from midline. But shoulder abduction, I know that it's very proximal, which means that mostly the nerves that are innervating here are going to be from C5. This means that if my shoulder abduction is perfect, I can tell that my C5 root is healthy, or the C5 spinal cord level. So the spinal cord itself is healthy, and etc. You get the concept, hopefully. And then we can clinically correlate it to certain conditions. You guys will visit this in your clinical lectures. طيب, how can I test? Another way is going to be my dermatome or myotome or reflex. Now, what's important for you guys in your lecture is the reflex and the dermatome. But specifically, what's a dermatome? Recall my dorsal root ganglion that we discussed in the beginning. Right here. This dorsal root ganglion, coming off of it is going to be, or before it is going to be pure sensory neurons. Now this can go, and there's certain areas of the body, each patch of the skin is going to be, if I trace it all the way back to the dorsal root ganglion, I will find one level, one nerve, okay? The dermatome is basically an area of the skin supplied by one dorsal root ganglion. This means that specific areas, there's many dermatomes, and dermatomes actually overlap, but clinically, these are the dermatomes that you want to look at or memorize really quickly for the purposes of your lecture. So for example, if I were to test the sensation, the movement and the sensation of my thumb, this tells me that my C6 spinal cord level is healthy. I hope this makes sense, because I know it's a pretty complex or abstract concept for you guys since you haven't taken neuro yet. But again, spinal cord level, C6, is going to be healthy if the movement of my thumb or the myotome and the dermatome or the area, skin patch supplying the single area of the thumb, this tells me that the C6 is healthy. It's working. Same for C7 and C8. You guys memorize these. And for the stretch reflex of the upper limb, I'm going to explain to you guys reflexes just very briefly and quickly. And of course, you guys don't have to know the details. Mostly what you have to memorize is the reflexes, the stable, memorize it really well. But how does a reflex work? So actually, in our muscle tendons right here, so let's say the bicipital tendon or the patellar tendon, the tendon of the knee, when I hit it, I stretch a receptor inside. It's known as a stretch receptor. When you hit a muscle, you actually stretch it. So this receptor will sense, so sensation, it's sensory. It's going to go from the dorsal root ganglion to the dorsal side, to the dorsal horn, and then it's going to communicate with the motor function. That's how a reflex works. It's going to communicate with the motor neurons, and it's going to go and cause for muscle contraction, okay? Ignore that contraction, it's not biceps. But anyways. Why is it not moving? Anyway, so this is the reflex arc. Now, the reflexes that you guys should memorize are going to be the following in the table. Please memorize these well and memorize which muscle is tested and which segment of the nerves are you testing, okay? طيب. Now we've reached the arm. Hello? I hope it's working. Anyways, Bismillah. Now moving on to the arm region. Now the arm region, the thing, I think now, okay, I figured it out. Like, now for the arm region, it's pretty simple. But the way that we want to, first of all, divide it is into an anterior and a posterior compartment. And we discussed about the innervations and kind of sometimes the arteries about them, but we're going to go more into details. And for the arm region, we have actually fascia. Fascia is just a very thick kind of connective tissue that wants to wrap or saran wrap the muscles to turn them into compartments. It's very neat because this means that I can group the muscles into either flexors or extensors. No, again, we've returned to the overwhelming tables, but again, they're a lot easier in the arm because notice how the first three muscles are actually flexors. What are they all innervated with? The musculocutaneous. And then we're going to have the triceps and anconeus, which are going to be posterior muscles. And again, what are they innervated with? The radial. طيب, let's go and revisit the skeleton. طيب, moving on. I'm just hoping the audio is working. Anyways, the first of all is going to be the coracobrachialis. From its name, coracoid is going to be its origin, and it's going to go and sit somewhere at the, what was it called? The humerus. Do you have to know the details as much? Not really, because these muscles are very simple, but it inserts at the medial third of the medial surface of the humerus, essentially meaning medial humerus. Now imagine this is going to be somewhere around the coracoid and it's going to be the origin. And then it's going to go and stick to the medial side of the humerus, which means that when the fibers are contracting, it's flexing the shoulder joint. Please do not confuse this and say the elbow joint. It has nothing to do with the elbow joint. It will simply flex the shoulder joint. So see, even when my muscle is straightened out, when my arm is straightened out, I'm flexing at the shoulder joint and abducting, of course. For the biceps brachii, from its name, biceps, it's in the name, it's telling you that it has two heads. We're going to have here the long head and the short head. We're going to have the long head laterally and the short head medially. So the one attaching two heads, actually. One, recall how I told you that the glenoid labrum will actually have a kind of tendon coming off of it and then moving in the bicipital groove. This is going to be the tendon of the short head of the biceps brachii. Sorry, I keep confusing them, the long and short head. But anyways, they're going to go and attach where? At the, I believe, radial tuberosity. Yes, exactly, radial tuberosity. So they're going to go from there, from all the way from the shoulder, imagine, and then all the way travel to the radial tuberosity, or basically the lateral side of the arm. So when they're flexing, they're crossing the elbow joint, which means that they will flex the forearm and supinate the forearm, okay? Fine. For the brachialis, it's going to be at the lower anterior surface of the humerus. So right here, the humerus, at the lower anterior surface. So somewhere right here, lower anterior surface. So right here. And then anterior surface as in, like, again, recall the basic anatomical position. And then it's going to go and attach to the conoid process of the ulna. So the biceps brachii is going to go lateral to the radius, and the brachialis is going to go from the lower side and then go to the ulna. So like this, they're going to be like this. So right here is going to be my biceps brachii. Right here is going to be my brachialis. طيب, what will it do? Of course, since it started from the humerus, crossed the elbow joint, and then went to the ulna, it means it will flex the forearm. And then the triceps and the anconeus, which are going to be my extensors of the arm. So where will they be? We said all of the extensors. Whoa, we jumped. All of the extensors are going to be at the back side of the arm. So we have triceps brachii. So biceps was two heads. Triceps will actually be three heads. Right here, you can see we have the lateral head, the medial head, and then the long head in the center, okay? طيب, what will it do? Extension of the forearm. And you guys can revisit the origin insertion, but for the sake of time, I won't. And then we're going to have the anconeus. Now, anconeus is very interesting in how it looks. It will actually go to the, I believe, medial epicondyle, right? Sorry, the lateral epicondyle of the humerus. So right here, the lateral epicondyle, and goes to the radius. So it remains, the anconeus is truly lateral. It's going to go from the lateral epicondyle and then go to the lateral bone, which is the radius. طيب, what does this mean? This means that it will extend the forearm. But most of the function is going to be triceps, because triceps has three heads, it does most of the work. And it makes sense because since one muscle is doing most of the extension of the arm, this means that it should be bulky and has multiple heads. Now the nerve supply will be radial, and I hope you guys know by now that posterior compartment will be radial alongside accompanying the profunda brachii artery. Perfect. We moved on to the arteries of the arm. Just one note about this is in Dr. Olena's lecture, but since we just did the what was it called, um, the brachial plexus lecture, this is essentially a map of most of the things that were discussed in the brachial plexus lecture. It's just repetition. So please go through it. And this is actually a really nice map for the sensory innervation. But again, make sure to go through this on your own time. طيب. For the arteries of the arm, again, we set in the neck subclavian, then after the lateral border of the first rib, it's going to be axillary, the first part, second part, and third part in relation to the pectoralis minor, and it's going to be wrapped around this axillary artery, the brachial plexus. And if in case we were lost, we're going to revisit the M, and that's where we are going to go. Now, after we've passed by all of these things, and we are now distal, we're going to become the brachial artery to supply the arm, the blood supply of the arm. طيب. Medially though, I want at the medial 1/3 or the proximal, at the proximal and medial 1/3, it's the artery will start off more medial. But as it's going, specifically at the distal half of the humerus, it's going to kind of wrap around and recall at the supracondylar region. We had the median nerve and the brachial artery. So this is where the brachial artery and the median nerve will meet, because it's going to go and kind of go from medial side and drop to become exactly median with the median nerve, okay? And then it's going to go pass by the cubital fossa, which we'll discuss in a second, and then splits into the radial and ulnar artery. طيب. Profunda brachii artery, we said it, it's going to accompany which nerve? Radial. I hope you guys said that. And it's going to be posterior in the radial groove. We're going to have the nutrient arteries to the humerus. They're just kind of a bunch of short fibers that just pierce and go through to the bone to supply it. We're going to have the muscular branches. They're not shown here, but again, they're the same concept as the humeral nutrient arteries. They'll just be small branches that are supplying the muscles. It's kind of like a network coming off of the same brachial artery. And then we're going to have the radial and ulnar artery. As I told you guys, after it passes by the cubital fossa, it's going to split into radial and ulnar. Now, we had bypasses in the scapular region for the shoulder joint. Do we have the same thing for the arm? Yes, we have the superior and inferior ulnar collateral arteries. Right here, you can just see that they kind of bypass. They're smaller, and there's two of them, the superior and the inferior ulnar collateral. That's pretty much it. For the veins, it's pretty much the same thing, nothing new. Basilic, cephalic, and we know how they're going to go and anastomose and go to become the subclavian vein superior to the pectoralis minor. Now, for the cubital fossa, it's bringing in everything we know together in the arm. Now, some of these muscles are going to be in the forearm lecture, which is why we don't go into details of them, but I just want you guys to know the borders. Now, for it to make sense, I want you to observe, this is your arm, and this is where the cubital fossa is. The cubital fossa borders are going to be like a triangle, like this. Okay, and we're going to discuss the borders of this triangle now. But now I have my triangle right here, right? This is going to be the borders. Now, superiorly, I have a roof. Inferiorly, I have a floor. And then I'm going to have the contents, the superficial and deep contents, okay? So I hope you guys now are imagining it as a sort of cave. This is the opening to the cave, and I'm going to have walls to the cave and floor to the cave, okay? طيب. First of all, the borders. We're going to have laterally the brachioradialis. So let's say that this is going to be lateral. This is going to be brachioradialis. This is going to be pronator teres. And this line right here is going to be the line of the condyles together. So right here, the condyles together are going to be the superior line, okay? This. So right here, whenever you guys see this red line in the diagrams and textbooks, this is actually a line connecting the humeral condyles. It's an imaginary line to just show you the superior border of the cubital fossa. Then the floor, we're going to go floor. So again, we said we're going to have the roof and then the floor of the cave. So the floor of the cave is going to be skin and fascia, most superficially. Then the bicipital aponeurosis. Then the deep neurovascular structures, which are going to be the deep contents. A good mnemonic for them is MBBS. We're going to look at them right now from medially to laterally. And this matters for OSPE. This is very OSPEable concept, by the way. So make sure, again, to observe it on the arm of the cadaver. طيب. For the floor, this is a concept I want you guys to know. So first of all, we're going to start off with skin and fascia. Now, actually, above this, under the skin, right under the skin and fascia, we're going to have our nerve. Sorry, not nerve. We're going to have our vein. Specifically, what vein? We're going to have the cephalic and basilic veins, صح? طب recall how I told you there's a cute connection between them from the cephalic going all the way to the basilic. It's bridging them. This connection is directly going to be at the superficial structures of the cubital fossa. Why is it important? Is because recall how when you go to the doctor, you probably had your vein punctured here for them to be able to draw blood. This is a perfect access for us to be able to retrieve blood because of this cute communication between the cephalic and basilic vein, okay? طيب. Another important concept is notice how it's very, very superficial. Underneath this vein is going to be the bicipital aponeurosis. Why do I care about that? Now, the biceps tendon, this is the biceps tendon, and then I'm going to have a sort of sheet coming off of it that's going to be a very thick, again, connective tissue. This thick connective tissue, again, imagine that we're going to go and puncture this area right here. I can reach the vein, but I need something that protects underneath the important neurovascular structures, which are basically the arteries and the nerves. What are these structures? Medially to laterally, they're going to be the median nerve, brachial artery, biceps tendon, and superficial branch of the radial nerve. Okay? So memorize these from medial to lateral and know how they're placed in the cadaver. And we mentioned all of the superficial structures, but I hope this concept is clear. We're almost done. Now I'm just going to put some miscellaneous concepts in the lecture and hopefully call it a day. But first of all is venipuncture. We said it when we want to draw blood or even infuse. So put a feeding like saline, which is basically just fluid. Give the patient fluids. Where do we go? We can access this right here, the cubital vein, medial cubital vein. And again, remember that it's above the bicipital aponeurosis, which means that we won't be able to puncture the neurovascular structures easily. So look how she's going with the needle, and we're not worried about the nerves and the arteries because there's the bicipital aponeurosis covering them. And more superficial to them is the median cubital vein. طيب, then we're going to have control of blood pressure. You guys will learn how to take blood pressure in pro next year. But for now, what we do is basically cuff around the arm. And the whole idea is we want to cuff the bicipital artery. Bicipital, I meant the brachial artery. So right here we have the bicipital tendon, and accompanying it, if you guys remember the MBBS, is going to be the brachial artery. Now, 5 to 2 centimeters above it, we're going to place the cuff, and we're going to inflate it. Now, before we place the cuff, we're going to put our stethoscope and then wrap the cuff around it. We're going to be listening in the stethoscope, and we're going to hear basically the spurt of the pulse, basically, the blood moving, and this is going to be the pulse. First of all, you're going to keep on hearing sound, tuck, 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 tuck. That's going to be your systolic blood pressure. The second the sound stops, and then it stops, this is going to be your diastolic blood pressure. The normal range, of course, is 120/80. I don't see how she'll ask about this. She probably won't. She just put it as a fun fact, probably. But the whole idea that I want you to take from 2 of these slides is that the cubital fossa is a great area for multiple structures, important structures to meet, which is why it makes it the optimal place for me to take my blood pressure and the optimal place for me to withdraw out blood, administer anesthetic, whatever it may be. Blood pressure points to controlled bleeding. These are simply areas that you must memorize. They're areas where I can press. So for me to stop bleeding, the best way to stop bleeding is to directly clamp or press on the artery. These arteries, you need to know it. Notice how all of these arteries, one thing that you need to notice is that they're all against bony projections, which means that I'm almost like, imagine this is going to be an artery and it's open. And right close by it is a hard structure. Now imagine if another artery or another soft tissue was around it. This means that when I go to press it, it won't be pressed very efficiently. So anything that under it is a bony structure is the perfect area for me to kind of press and clamp. So these areas are perfect for me to control bleeding, okay? Memorize these. The last concept is going to be Volkmann's ischemic contracture. She didn't really go into details about this, but what I want you guys to know is, first of all, recall the supracondylar region. We're going to have the brachial artery accompanying the median nerve. If I were to break the supracondylar region, I were to have a break to it, I can suffer a clinical concept known as Volkmann's ischemic contracture. Now, because the brachial artery will feed literally my whole arm, I'll have ischemia, which is basically the oxygen is deprived from the muscles of the forearm. And what will happen is these muscles will become stiff. So since the muscles of the forearm became stiff, the patient will present like this with like a sort of dry or contracted arm. So this happens with supracondylar fracture. Is this the only case I can have this ischemic contracture? No, it's any case that will cause for the brachial artery to stop feeding the muscles of the forearm. This could happen in compartment syndrome. You guys don't need to know the details of it, but compartment syndrome is basically when I put on a cast too tight. That's not the only way we can get compartment syndrome, but for your knowledge for now, let's say we put a cast too tight. This means that since the fascia of the arm is already tight enough, and now I put on top of it something even tighter. This means that the structures, the important vital structures such as nerves and arteries, are going to be compressed. Now, if you compress an artery, what will happen? You stop the blood flow, which means that, again, I'll get ischemia to the forearm muscles. They're going to contract because of the ischemia, and I'm going to have Volkmann's ischemic contracture. That's pretty much it. Like, for the bones of the upper limb, we're going to look at them radiologically. Now, radiology is actually very important. Please, please, please make sure to study the pictures of radiology from OSPE, especially very well, because chances are they'll bring a radiological picture in SAQ with a case and ask you to interpret, like, or ask you what disease is going on, okay? I hope that made sense. But anyways, the way you want to read an X-ray, first of all, is I want to take you through the ribs. This is the clavicle. This is going to be my scapula, and this is going to be my humerus. Now, when you want to read radiology pictures, don't just look at them straight up. You need to follow them and trace them with your finger. So let's take the ribs, for example. Now, actually, these horizontal lines, you might think that they're the anterior part of the ribs, but no, these are posterior ribs. So these horizontal lines, you want to count them. Do I just count them and move on? No. What I need to do is count them and trace them as they curve. Because notice how the curves kind of sometimes overlap. So you need to make sure of what you're counting, okay? So 1, 2, 3, 4, 5, 6, 7, 8, okay? We're done with that. Nothing wrong with the ribs. Then move on to the clavicle. Now notice how it's going to be the thick triangular medially, and then laterally it's going to taper out, and then articulate with the acromion process. So acromion facet and acromion process. They're gonna articulate. طيب, what's underneath is going to be the coracoid process. This is going to be the suprascapular notch where the artery and nerve will pass by. This is going to be my glenoid cavity. صح? Looks good. Then I'm going to have the head of the humerus articulating with the glenoid cavity. They're in good shape. Nothing is wrong with this. No fracture of the anatomical or surgical neck. This is a clean radiograph. Now I put this picture right here. I hope you guys can kind of stop and also trace. It's a good exercise and name every structure here. And this is the answer. Hope you guys actually paused and tried to practice. But two concepts here that were randomly placed in Dr. Yasmeen's lecture, and I'm going to explain them. So first of all is the comminuted fracture of the clavicle. Now recall how we said that the clavicle will fracture most probably at the middle portion because it has the least amount of reinforcement. Usually, sometimes fractures, not only in the clavicle, generally, bones when they fracture, they can either have a simple fracture, which means that the bones are discontinuous, but they're still in place. It's as if they weren't displaced, like they're still in place. So I broke the bone. So this is the normal bone. I broke it, but they're still in place. They're not moving or overlapping. I could have a comminuted fracture, which means that the bone pieces now have been scattered. One moved anterior, one posterior, one, like they're not aligned anymore. So this is a comminuted fracture. It's kind of a really bad fracture to have because usually you have to go surgical rather than just putting on a cast. This is a comminuted fracture of the clavicle. And again, please follow the rules of tracing everything to find out what's the pathology. The second thing is going to be the proximal humerus physeal fracture. Recall how I told you that we have two necks of the humerus, the anatomical and the surgical. Anatomical neck is going to be where the physeal, what was it called? The physeal plate or growth plate is going to be. This is where once the patient has grown up, or once the person has grown up, these plates will actually close up, and this is where the bone will grow. If I were to break at the anatomical neck, this means that I'm disrupting this physeal or growth plate. And this is a very bad fracture to have again, because if I didn't tend to it correctly, it can affect the growth of the person because you're literally breaking the growth plate. And that's pretty much it. Thank you guys so much for sticking this far. I know that this session was pretty dense, but inshallah, this crash course was able to help. Please, please, please make sure to solve as much questions as possible. You don't have to go to every single resource ever. Like I remember our batch would collect from 5 textbooks, and the question file for one lecture would be like 40 questions. It's way too much. You won't have enough time for that. But what I recommend is pick 2 sources from these, like maybe Grey's Anatomy and one other book, solve these questions, and then move on. Move on to the next lecture. Your saving grace this block will be hands-on practice on the cadavers, on the models, everything in lab. So after you guys have reviewed your lectures, done crash courses, whatever you want, go to the lab and study this. Um, even if you have some friends that could help study it with them. But again, saving grace for this block, I remember I crammed this block in like 3 days, but I spent the entire time of the block attending lectures and then going to the lab and applying whatever the lecture said, okay? It will give you a real sense of what could be asked about and what can't. And this is going to be a questions file. I collected all of the questions from Dr. Yasmeen's crash, the QR code, Olena and Vlad, so you guys can have practice right there. And that's pretty much it. Thank you guys so much for sticking this file. Oh, best of luck with your MOM final and MSK final. And genetics. Genetics is going to be around probably. Thank you guys.